Okay, I think we'll get started. Thank you all very, very much for coming today. What we hope to accomplish during the day today is get you excited about hydrocephalus research. I'm going to introduce a new hydrocephalus research center that has just been initiated on this campus. And my co-MC, Dr. Shah, is going to be talking about research on the medical side. What we hope to accomplish is to try and stimulate collaboration from the basic sciences through all of the clinical sciences. We are talking about drug development in some of the studies we're doing. We're doing a lot of preclinical work, and we'd love to partner with some of our medical colleagues to move some of those forward as this becomes available. So I'm Bonnie Blazer-Yost. I am the director of the New Hydrocephalus Research Center. Our manager, Sarah Connors, is here today. Sarah, would you stand up? She's a good person to contact if you want to know more about the center or to make contact with us. And all of our emails are on the program that you got. So please feel free to take that. For those of you who are joining us remotely, first of all, I'm really sorry that we won't have time to take questions just because of the number of speakers we have and the logistics of all of this. We're very happy that you are joining us. And again, all of the speakers have agreed to have their emails put into the program so that if you contact any of us, we can send you a copy of the program if you don't already have it. And we are trying to get people to talk to each other. So please feel free to contact any of the speakers or any of us. There is going to, for those of you who are here in the audience, there's going to be a reception between 5 and 6 today. Even though we are on the undergraduate side of campus, we have managed to get permission for beer and wine. So please stay and mingle with us. There is only one bio break that we have put in to this program. And just let me tell you that if you go straight down the hall here, turn right out of the door, go down to the first hallway that is perpendicular. The elevators are there and the restrooms are right on the other side of the elevators. If you do need to get up and take a bio break, please feel free. Those of us who teach in these rooms are very used to people getting up and moving around and going out and coming back in. So please feel free. First of all, I'd like to do a big thank you to Lindsay, Jill, and Sarah. They have been fantastic in helping to plan this program and bring us all together. I'd also like to thank both the Dean's Office here at the School of Science and the Neuroscience Institute for support, for personnel who have helped us plan this event. And this is truly put on by both the Neuroscience Institute and the Dean's Office. I think Dr. Shah is going to talk more about the Neuroscience Institute and fill you in a little bit more about that. I'm going to tell you a little bit about the research that we're proposing to do in the Hydrocephalus Research Center. So in the center, we have a number of different investigators. The center was created because of 2 DoD grants, Department of Defense grants. It was written into one of those grants, and we said we were going to put this together. The people listed on this slide are all part of those grants. So you see the current students and staff in my laboratory. We are going to be joined, the grants just started recently, so we're going to be joined by 4 additional people. Dr. Bilecki Adams will be speaking a little bit later, and she will be introducing her research. There are two investigators, they're co-principal investigators with Dr. Bilecki Adams and I, Dr. Shenandoah Robinson and Dr. Lauren Jensky. They are part of one of the two grants, and Lauren was going to speak today, but unfortunately, she was in a very serious car accident yesterday afternoon, so she will not be joining us. I'll say a few words about their combined research in a little bit. And then at the Purdue School of Veterinary Medicine, our investigators and the co-PI there is Dr. Tim Bentley. He's going to be joining us in a few minutes to talk about an animal model. He is in Britain at the moment, so he'll be joining us from Britain to tell us about the animal model that he was instrumental in creating. It is a pig model. And for those of you who know anything about drug development, going into a pig model is the next step, or the final step in preclinical work before going into humans. So we're very excited about that. He is joined by Greg Knipp and Robin McCain, who are both at Purdue and do all of the pig work, the pharmacokinetics, pharmacodynamics. Purdue is amazingly set up to do large animal studies. And finally, we have Scott Mitchell, who is from this university, from the School of Medicine. And Scott has been collaborating with the Purdue group, learning how to do the induction of the pig model, and has been working with them. And we're very happy to have Scott with us as well. So this is preaching to the choir. You all know this. There are no effective drug treatments for hydrocephalus. So our research center has three major objectives. We want to understand the pathophysiology of hydrocephalus. We want to understand that at a molecular level, a cellular level, a physiological level, because I think it's only by understanding the disease process that we can effectively do treatments and develop drugs. And that brings us to our next goal, and that is to identify drug targets, potential places where we could intervene in the development of hydrocephalus and effectively treat it without brain surgery. And finally, we're using a lot of different preclinical models. We have 3 different rat models, we have a mouse model, and now we have a pig model. And that too is very important when you go into drug development, because a single model is not going to cut it. You can't assume that a mouse brain is equal to a human brain. Pig is about as close as we can get, but we're looking for things that are common to all of those models, and we'll be talking about those. Now, I'd like to mention give you a little bit of history of how this developed. I was by training a renal physiologist. I am not was not a hydrocephalus researcher. I am now. And it was just a serendipitous observation in an animal model we were using to study polycystic kidney disease that led me into this. And when one is making a transition like that from one field to another, it is very hard to get funding because you have no standing at all in that field. So what was key to get started was pilot funding. And the first external pilot grant that we got was from the Hydrocephalus Association. It was a Team Hydro award. And 3 of the people from the Team Hydro group are here today. Pam Finlayson is going to be talking to us later and telling us a little bit about Team Hydro. But that first grant was absolutely instrumental in being able to continue with the pilot studies that we were doing. I have to also acknowledge this university because throughout that whole time, I had a lot of different pilot grants from the university. And a lot of those in collaboration with people at the medical school, and those two helped us. More recently, we've gone into another drug target that we are not yet funded for at a national level. And again, Team Hydro, through the Hydrocephalus Association, gave us a second award that allowed us to develop that into animals. Oh, sure. Sorry. Thanks, Mike. So, is that better? Thank you. That funding, that pilot funding, led to a Department of Defense grant, and you might ask why the Department of Defense. One of the things that causes adult hydrocephalus, so you may all think of hydrocephalus as a pediatric disease because that's where it is most visible. In children, their skulls have not ossified. So if this cerebral spinal fluid builds up, then their heads get big. So I think most people that are not in the field, when they think of hydrocephalus, they think of pediatric hydrocephalus. But it turns out that the incidence of adult hydrocephalus is every bit as common as the pediatric form, and can come from a number of different causes, things like stroke, traumatic brain injury. There is a disease of the elderly called normal pressure hydrocephalus. I don't know if Dr. Williams will be talking about that or not, but there are a number of different forms of hydrocephalus, and the Department of Defense, of course, is most interested in the traumatic brain injury form. But the Department of Defense has an unusual basic research funding profile, and they fund a lot of basic research that is not necessarily related to their main mission, their main military mission. So this has led to two major DoD grants, a Focused Program Award and an Expansion Award. I'll tell you a little bit about the specific aims. I'm building up to the specific aims of these grants, because that is what the center is going to be doing for the next 4 years. These are new grants. One started in May and one started in September. On the Focused Program Award, there are 3 equal principal investigators. Dr. Bilecki Adams is going to be speaking today. We'll say a few words about Dodie Robinson and Lauren Jensky. Their research, as I say, Lauren was going to be here today, but couldn't because of a car accident. And then the Expansion Award is with the investigators at Purdue, which I just mentioned. So looking at the Focused Program Award first, Project 1, there are 5 projects, 4 of which are funded. Project 1 involves all investigators, and between us, the investigators have 4 rodent models, 2 genetic and 2 induced. So we have a post-hemorrhagic model, a post-traumatic brain injury model, and 2 genetic models. Here at IU, we are studying a potential drug called a TRPV4 antagonist. We have found that in our model, it is very effective. At Hopkins, they're using a combination of erythropoietin and melatonin in their models, which are the induced models. So what we're going to do in Project 1 is test all drugs in all models. And after we've tested all drugs in all models to find out which ones cut across all of those models, then we're going to put all 3 drugs together, because the TRPV4 antagonists probably hit the fluid secretion aspect of hydrocephalus. the erythropoietin and melatonin hit more the neuroinflammatory, and they're also neuroprotective. So we feel that together, this triple co-therapy may be very effective, and we're doing that too in all models. From that point, we go into the individual projects, and I have listed those there. My expertise is in fluid electrolyte balance, and so we're going to be doing that a lot, both in animal models as well as in cell culture models. A senior graduate student in my lab, McKenna Reed, was very interested in astrocytes and has spun off a project looking at astrocytes, which has become very interesting and is a part of this work as well. Then Dodie Robinson is looking at a traumatic brain injury model. Lauren Dansky is looking at chronic inflammation and post-hemorrhagic hydrocephalus. And Terry is looking at vision and sleep disturbances, and she'll be talking about her research in a moment. For the expansion award, as I said, we're going to use the pig model of post-hemorrhagic hydrocephalus, and in there, we're only going to test the TRPV4 antagonists. Pig studies are horrendously expensive to do, so we're going to start with one drug in that. As we're doing these animals, we're going to be collecting their brains, we're going to be collecting their cerebral spinal fluid, and we're going to be doing a lot of work on looking at what is affected not only in the area of the ventricles, but all over the brain. We're going to be looking at a lot of different things. And then we're going to also use a cell line in an iterative process to go back and forth with what we find in the animals and test that in a cell culture system. So the goal of creating a center is to facilitate collaboration. I have my email there, I put Sarah's email there, and we would be happy to have you contact us if you would be interested in any of the research that we are doing. So that, I hope, gives you an idea of what we're doing as far as basic research is concerned and preclinical development. I would now like to introduce my co-MC, Matish Shah. Dr. Shah is a professor of neurological surgery and the Paul B. Nelson Endowed Chair. He is also currently chair of the Department of Neurological Surgery at the Indiana School of Medicine. He is one of three co-directors of the Neuroscience Institute, who is co-sponsoring this symposium. So please, Dr. Shah.
So thank you, Bonnie. I think I'm holding this high enough. Sorry. We need to do.
Is it better?
Okay. All right, I think that's close enough. Well, it's really a pleasure for me to be here, and just to show you what it takes for collaboration to occur. A single email from Bonnie announcing that she had received this grant led to so many things in such a short time period. The development of this symposium was one of them, but I think I invited you to listen to one of our Carlsbad professor lectureships, which was John Kessel, who leads the Hydrocephalus Research Network. And that presentation and you being there allowed you to see how many other people in our clinical department were actually interested in hydrocephalus work. And now we have one of our residents working with you in the porcine model, And then just recently, I shared with you an email from a potential candidate who's looking at a pediatric neurosurgery section chief position who's doing work in hydrocephalus. So, and his wife is part of the Hydrocephalus Association. So what a small world we live in today. So let's see. I'm going to begin. Thank you for the nice introduction, to tell you that I wouldn't be a neurosurgeon had it not been for hydrocephalus research. So my career started, I would say, in neurosurgery in between my freshman and sophomore years in medical school, where I decided to work in Pat McAllister's lab for a summer project. And I actually made newborn rats hydrocephalic using a Kalin model. I thought I'd never, ever talk about this project before in my life again. And I thought it would be interesting for you to see the journey that your life could take. Many of you are students out here that you never know what's going to come back to be utilized in your career in the future. So I actually had the honor of publishing this paper with Pat, and his mentor was Ray Truex, who was a pediatric neurosurgeon. And it was the collaboration between the clinical work and the basic science research that got me interested in neurosurgery. We actually won third prize at a University of Miami Symposium, and that led me to develop my interest in my career here. So many of you have heard about the new academic health center, which is really what's exciting to me. It's not about the buildings. It's really about the health district, the creation of a 44-acre facility that will have green space in conjunction with all the brand new buildings. Some of you may or may not know this. This project is the largest healthcare project in all of North America currently, and it may be in all of the world. Brian Nagy, the president of the HC, is trying to figure this out. The hospital complex is going to be spectacular. It's a 16 unit tower that have 3 towers actually. There'll be 50 brand new state-of-the-art operating rooms, 380 new clinic exams. Do I have this? Yeah, I want to show you this. So the main hub of neuroscience work will be in Goodman Hall, which is the neuroscience center that includes both the research center as well as the clinical piece, which is on the right, the left-hand side here. And then the development of the new IU School of Medicine, Medical Education and Research building. I believe this is the first time in the school's history that the project of this scope will be put in Indianapolis in 50 years. So it's a long term, or it's a long time in coming actually. But what's very unique about this is that the adjacencies of the people who are interested in both the neuroscience space and the clinical world of neuroscience will be right next to each other. But you folks are just 5 minutes away, actually, it turns out, which is fantastic. And this is a beautiful facility. So I'm looking forward to more collaboration. More than the buildings, it's about the programs that we can develop. And today is a great example of this. So the School of Medicine and the healthcare system has decided to invest their funds into 3 major institutes: the cancer, the neuroscience, and the cardiovascular institutes. So what this means is that we're going to transcend the old typical models of doing projects and programs inside of departments or service lines. For some of you, you might not know what a service line is, but that's things inside the hospital, like the spine service or the orthopedic service or the neurosurgery service. What they're concerned more is with clinical output and clinical parameters. They're not as much interested in what the school and the healthcare calls the tripartite mission of patient care, research, and education. So this is something that the institutes allow us to break down sort of the walls and then not create silos that we've had in the past. The Neuroscience Institute has 6 centers that we are going to focus in on. So those are the Neurodegenerative Disorder Center, spinal disorders, neurovascular, the Center for Neurotrauma, and neuromuscular disorders. And the most recent center we've added is the Center for Neuro-Oncology, which will be a joint venture with our cancer center. I'm happy to report that we have at least 3 center directors that have started. Donna Wilcock will be the leader for our Neurodegenerative Disorder Center. The Spinal Disorder Center is led by David Stockwell, and the Neurovascular Disorder Center will be led by Rick Shear. We're looking for center directors for neurotrauma and neuromuscular disorders. We have named a neuro-oncology center director who will start in the first quarter of 2024. Aside from the centers that we're trying to develop, the healthcare system wants us to create destination programs or centers. And so what this means is these are areas of expertise because of various things like our personnel, our infrastructure, equipment, that allows us to make programs that bring people from all across the state and, for that matter, all across the country. So for example, this year we were fortunate in that we were able to consummate our first destination center in skull-based surgery. We're working on things like a pediatric brain tumor center, brain med center, and it would be our goal to eventually even do research centers like the Hydrocephalus Research Center inside the Institute. We were very clear that we wanted to make sure that dollars were being spent properly. So we asked for what are the measures of success so that both the school and the healthcare system was clear on sort of the mission. And so here are the goals. The clinical growth. Patient care is the single most important thing about the Institute, so having market share. But more importantly, to the School of Medicine, it was about NIH funding, US News World Report rankings, the importance of having high impact clinical trials, as well as making sure our quality and safety metrics were being met. And most importantly, to also make sure that the education mission of the school was not being lost by developing programs. So this is my team of 13 adult neurosurgeons that cover the academic health center. We have 4 pediatric neurosurgeons. Many of them actually have interest in hydrocephalus. Jesse Savage, for example, he's the site PI for our PENS trial, which you may be hearing about. That is the trial to look at the role of shunting in NPH patients. We have Rabia Kaiser, who's actually looking at models for understanding what happens to shunt catheters and why they fail by looking at the cellular pathology around the shunt catheters. And then Jignesh Taylor, whom you'll meet later, I'll talk more about what he's actually working on in his introduction. This is our basic science team. We currently have 5 basic science faculty members, and we're starting to grow more of them. And we have 3 surgeon scientists currently. So Doctors Dang, Liu, and Wu and Gao are predominantly working in our spinal cord and traumatic brain injury lab. Nuruddin Manti is working on neuro-oncology projects along with Angela Richardson and Jignesh Taylor. Matthew Pease is our most recent hire, and his main focus is data science and using AI and machine learning to in the realm of predictive medicine. So to achieve the goals of the centers, we also believe that certain cores have to be developed. So we have a very strong core in things like neuroimaging, genetics, biomarkers, and therapeutics and interventional core. We're developing stronger cores in bioinformatics and healthcare information core. And then with our co-director's interest, there's going to be a strong clinical trial methodologies core, along with the neuroscience outcomes research core. So one of our goals is to really talk about what are the entities that are present inside the healthcare system and the school that allow us to operationalize these cores. So some of these entities include the Indiana Clinical and Translational Science Institute. This is a statewide research partnership between IU, Purdue, and Notre Dame. And the key elements of support include things like service cores in bioinformatics, genomic and proteomic analysis, and our biobank. We have over 1,000 brain tumor specimens in our biobanks that is run by the CTSI group. CTSI also works on community health partnerships, global health programs. Our team actually recently went to Kenya on a camp for neurosurgery, biostats, epidemiology, and research design. And they also run career development, education, and research training. And then we have another entity called the Office of Clinical Research, which is a joint venture between the school, the university, and the healthcare system. And this helps investigators with contract negotiations, clinical research training, and support and analysis of research billing. The final entity that I want to talk about is the Enterprise Clinical Research Operations facility. It specializes in supporting our research in complex clinical trials. So this particular entity has a high RN to coordinated ratio so that they actually provide 24/7 call cover services. So for complex clinical trials that, like spinal cord injury patients that come in all hours of the night, this particular entity helps us run this. But really, to ensure that IU is a future leader in high-tech clinical intervention and research, what we've decided to do is really to develop these innovations in neuroscience core more. And this is something that I have a lot of passion about. And so the way we are going to try to create this core and develop it is through 4 pillars. So what are those? Developing a surgical skills lab, a simulation lab, and a center that will house our AI, augmented and virtual reality center, our 3D printing lab, and then a translational research facility that will be a virtual center that will allow us to actually take all of the resources that are available across the state and collaborate in a way that we can actually, through the institute model, be able to bring projects in and increase the scope of the projects because of our relationships with things like Purdue University and the Engineering School, 16 Tech Innovation Center, which houses the IBRI, and the Indiana Center for Biomedical Innovation that are helpful in drug development, and then also things that we talked about at the Indiana CTSI. So we visited very many sites across the country to sort of model our surgical skills lab. This will allow us to train residents so they can do things like, Dr. Mitchell helping you with the animal models. The other thing that I'm very excited about is bringing in very new technologies. I call this the future lab: augmented reality, virtual reality, robotics. We have 3 robots currently in neurosurgery that we're using, and we already have some projects for 3D printing to help not only the education piece, but resident learning about anatomy, which is much cheaper than using cadavers. So we're really excited about what's going on in the Institute, and we really share our enthusiasm to develop more collaboration with things at the Basic Science School. So thank you for allowing me to present this.
Lauren couldn't join us today. What I'd like to do is just give you a little bit of background about our collaborators at Johns Hopkins. Lauren is a PhD. She is an associate professor. She is classified as a neuroscientist and a neuropharmacologist. She's an expert in neural immune communication and inflammatory signal transduction. Dr. Robinson, who is the other investigator at Johns Hopkins, and Dodie may be well known to those of you in clinical medicine because she's quite known in that field. She's a pediatric neurosurgeon scientist who cares for both children and adults with hydrocephalus. Her research on neural repair and erythropoietin has been approved for clinical trials, and those clinical trials in the pediatric population have been initiated. So that's very, very exciting, and we all look forward to seeing what goes on with those studies. Our next speaker is my friend and colleague, Terry Bilecki Adams. Terry is a vision scientist specializing in retinal health and disease. She's an expert in factors that trigger astrogliosis and microgliosis in retinal disease, and has been working a lot in inflammation. We have labs beside each other, so we talk a lot and have developed a common interest in the retinal, the eye problems that are prevalent in hydrocephalus. Terry, thank you. Yes, please, so I don't mess something up with the.
Thank you. Oh, okay.
You might have to.
Mhm. Okay, good afternoon, everybody. My name is Terry Bellicky Adams, as Bonnie said, and I'm going to give a different perspective than probably most of the people here. That is that I study the eye, and of recent, I have been collaborating with Bonnie and Lauren and Dodie at Johns Hopkins, and we've been looking at the effects of hydrocephalus on the eye in their induced model system of post-hemorrhagic hydrocephalus. So if we look, and this is probably a perspective that many people will never see in their lifetimes of the eye, we're actually looking from the back of the eye. So this, oops, sorry about that. Uh-oh, I may need help here. I don't know what I've, nope. Oh, here it is. Okay, I better not do that then, I guess. So this is from the back of the eye, and you're essentially looking at the optic nerve here, and then the eye is way up here. And so what I would like to tell you about here that we really haven't heard much about today is that the cerebrospinal fluid that circulates in the ventricles of the brain also circulates surrounding the brain in the subarachnoid space. And that is where we come into the effects on the eye, which is that here you'll see the subarachnoid space here, this little web-like gray structure running alongside the eye. That actually then terminates at the back of the globe here at the very tough tissue called the sclera on the outside of the eye. And so what you see is basically you have a very unique structure here in which the internal part of the eye here has an interocular pressure, and then you also have the intracranial pressure on the outside of the eye, and they're very balanced with one another. In addition, you also have the blood pressure, which the arterioles and venules run inside the optic nerve there, and so they're very uniquely balanced with one another. And so when one of them becomes unbalanced, that unbalances the rest of them. And so that's what happens then essentially when we're talking about hydrocephalus. So here we're basically looking at a normal retina on the inside, and now you have the optic nerve over here, and in blue is the subarachnoid space and the cerebrospinal fluid that's running in those. When you have hydrocephalus, you have an increase in that subarachnoid space. And there really is not much space for it to go to so when you have an increase in the subarachnoid space, it compresses on the optic nerve. That's running down the center here. And so when you have a compression of the optic nerve, quite obviously, you're going to be affecting the blood supply. In particular, you have a problem with the venous outflow from the eye. And you also have what is referred to as axoplasmic stasis, which is essentially an interruption in the flow of molecules down the axons to the target tissue, or in fact, back from the target tissue up to the cell bodies. And so That creates a lot of problems. This whole process here is referred to as papilledema. Okay, so this is what it looks like in a human when they look at an MRI. So over here, we're looking at a normal human, and this is the eye up here. So the MRI is essentially highlighting the soft tissue that has liquid in it. So that will show up as white in this instance, and then soft tissues that have less liquid will show up as gray. And so you can see the optic nerve here, and then this globe up here is the eye. And the reason why it's white normally is that there's a lot of vitreous in the center. That is kind of a jelly-like substance. And then you have aqueous humor up at the front here, and this little disc here is the lens. So this is the optic nerve back here, and alongside of it is running the subarachnoid space. And you don't see much white there, and that's because there's not a lot of cerebrospinal fluid there to begin with. In the case of hydrocephalus, though, this is what it looks like. Again, you have lots of aqueous humor there and vitreous humor, and you'll look back at the optic nerve and it looks quite different now. Now you can see that there's a buildup of cerebrospinal fluid around the optic nerve, and the optic nerve looks compressed or smaller. And that's what leads to all the problems. In this case, you also see kind of a flattening of the posterior sclera because there's a high level of pressure that's built up there, and it's kind of flattening the posterior globe. And it might be difficult to see, but you also have a little mountainous kind of process here. That is actually the edema that occurs when you have a compression of the optic nerve, and that's the papilledema, if you will. Okay, so there are lots of treatments for papilledema. However, none of them are particularly wonderful. So we've already heard about the ventriculoperitoneal shunt and the problems associated with the shunts. Patients can get Lasix, and that will help to decrease the swelling. Another surgical kind of procedure that can be done is the optic nerve sheath fenestration. And so this is what is shown in this picture here is the optic nerve fenestration. You have lots of problems that can be associated with these, such as bleeding and infection, of course. You can have scarring. You can have injury to the nerve itself during the procedure. And you may eventually have need for more surgery to open it back up if there's scarring that's occurring there. So none of these treatments is particularly wonderful, although they're helpful. But again, we have need for more kinds of interventions, particularly pharmacological. Now, papilledema is not just the result of hydrocephalus, but it can also be the result of multiple other types of diseases. Brain tumors can impinge upon the optic nerve and have the same kind of effect. Cerebral venous thrombosis can occur. Lots of things can actually lead to this papilledema. So again, by coming up with different kinds of treatment options, we may be helping out not just the hydrocephalus community, but also other communities as well. So what are we lacking? We're actually lacking a relevant animal model system in adults, okay? So what can we do if we have an animal model? Well, first of all, we can study the exact mechanisms that lead to the papilledema. Not just the early parts of the papilledema, but also what happens later during papilledema. We can identify new therapeutic targets. That, of course, is a big drive in the grant that we received. And then we can actually test some of these pharmacological treatments as well. And so Bonnie and the group at Hopkins both have their treatments that we're going to be testing to see how successful they are at reducing or getting rid of the papilledema. So as part of that, we are trying to then come up with an animal model. And so what would we look at? What would we look for if we were looking for a fantastic animal model? The first, of course, is that increase in the cerebral spinal fluid that is surrounding the optic nerve, like we just saw in humans. We're going to be looking for an increase in the width of the optic disc. That optic disc is the part of the nerve that's actually coming into the eye. And then we're going to be looking for an increase in the nerve fiber layer. That is basically the process of the axoplasmic stasis. So the axons get bigger as they build up protein that can't get out of the eye. And then we have changes to the vasculature, particularly venous engorgement is known to happen. And then finally, retinal ganglion cell death, which the retinal ganglion cells are the cells that are actually projecting out of the eye through the optic nerve on their way to the target in the brain. All right, so we know what we're looking for. And so the first thing that we did was we looked around for model systems. And of course, we have this very nice collaboration with the Jancy lab. And she has developed this model system where the first thing that they do is they inject lipopolysaccharide, which is basically an bacterial endotoxin that will increase inflammation. That is basically because inflammation comes in many forms with hydrocephalus. Then a few days later, there's an intraventricular injection of the littermate's lysed red blood cells. And then what that does is basically reduces the outflow of the cerebral spinal fluid from the ventricles. And that is going to lead then to the hydrocephalus. And so Lauren has seen in many of her studies that this treatment basically increases ventricular volume. As you can see here, the ventricular volume itself has increased, as well as the opening pressure of these post-hemorrhagic hydrocephalus rats, excuse me. All right, so we can see that this is a fairly reliable model. In other words, we can do these injections and repeatedly see that we get an increase in the intracranial pressure. And so now we can ask what happens in the eye. And so we did MRIs. That is, the we here is Lauren Jancy. I'm sorry, that's kind of missing here. Move that down. Lauren Jancy is a magical kind of, okay. Anyway, Lauren is a magical PI. She can do just about anything. And this is a fairly difficult procedure to perform in rats because their heads are so small. But she has been able to obtain these very nice MRIs in the rats. And so if you look here at the sham control, again, you can see very similar to what we saw before. You see the eye here, and on the inside, you see that humor. On the outside, you see the nerve flowing outwards, and along the side there, that dark black region is where the cerebral spinal fluid would be. And of course, in the normal animals or the sham animals, you don't see much of the cerebral spinal fluid there. And you can see that the nerve head actually looks fairly normal here. In the post-hemorrhagic rats, what you see again is a buildup of that cerebral spinal fluid, and it is compressing the optic nerve, just as you would see in humans. And it's difficult to see here, but you can see an increase in the optic disc region or optic nerve head. All right, so that's a good sign. Hopefully I can advance the slides here. So the next thing that we wanted to ask is, if we look at those optic nerve heads or optic discs, is the optic disc enlarged? And so to do that, we basically took sections through the eye, and we looked in the optic nerve head region, which is right here. So off to either side is the retina, which is that part of the brain that actually transduces the light signal. And then we have retinal ganglion cells out here, and they send their axons through this region out to the target, okay? So you can see in the naive, you have the typical looking optic disc here. And if you look in the post-hemorrhagic rats, you in fact do see a much larger optic disc region. And when we actually do the measurements and we compare them, there is a statistically significant enlargement in the optic disc width. in these rats. Well, that's one way to measure the optic disc. Another way is to look at the discs with optical coherence tomography, or OCTs. And in fact, this is what the OCT looks like. An OCT is basically the ability to look inside the eye. So you basically wheel a little camera up to the eye and you look at the inside, but it's non-invasive. Okay, you can look at the blood vessels here. So these are the blood vessels coming into or leaving the eye, and here is the optic disc. And so that optic disc region, if you take measurements of that, you can again see that there is an increase in the size of the optic disc. So this is just another measurement telling us that there is in fact an enlargement in the optic disc. All right. Well, eventually I'll get the hang of it. Now, another way that we can use the OCT is to actually look with frontal sections through the retina, and you can look at the retinal layers. And so this again is an en face look of the optic disc and the vasculature, and these are the sections through the retina, and you can see the layers of the retina here. So in the naive animal, you have a fairly normal looking retina. When you look at the post-hemorrhagic animal, there appears to be a decrease in some of the layers. We have these sort of strange structures popping up every once in a while, which we didn't really understand. We didn't know what those were. So we did histological sections again through those regions to see what we were looking at. So again, this is a normal looking retina stained with hematoxylin and eosin. And this is one of those regions that was highlighted in this picture. So if this green line is basically telling you where they took that section, the frontal section here. And when you look at that region in histology, you can see that rosettes have formed. Now, rosettes are found a lot in retinal diseases. It basically indicates that there's a loss of some of the structuring of the retina, and probably also a loss of function as well. And you can see that there is in fact kind of a reduction in some of the layers as well. All right, so that's telling us a little bit about what's going on there. The next thing that we wanted to look at though was to look at the nerve fiber layer. And we wanted to look at the nerve fiber layer because that is the region where those ganglion cell axons travel on their way out of the eye. And if you remember, I told you about the axoplasmic stasis and the fact that we might see swelling there in those axons if there is compression of the optic nerve. And so the person who did this, I'm sorry, Michelle, your name's not showing up here on all these, but the person who did this is sitting right there. And so when you actually measure the nerve fiber layer in the naive and then compare that to the post-hemorrhagic animal, you do in fact see an increase, but it is not statistically significant. And that is probably the only thing that we saw that was not statistically significant when we looked. All right. Now, the next thing that we looked at was to look at those retinal ganglion cells, just to determine if we were losing any of those cells. In other words, what is the health of those retinal ganglion cells? Once you lose those cells, you're losing part of your vision. So what Michelle did was to take sections through this, through the retinas of the naive and post-hemorrhagic model and stain them with markers for retinal ganglion cells. So she used BRN3A, which is a transcription factor found in retinal ganglion cells, and RBPMS, also found in only retinal ganglion cells. And so this is a typical picture you would see. The rest of the retina is up here, and here you have the ganglion cell layer, and you can see lots of nice little ganglion cells in there. And when you look at the post-hemorrhagic, you see that there is a large reduction in the number of retinal ganglion cells. And in fact, Michelle looked in several regions of the retina, 300 to 500 microns from the optic disc region, and then 1200 to 1450 microns from the optic disc, and 2000 to 2250, sorry. And what she saw was there was a loss of retinal ganglion cells in the region closest to the optic disc, okay? All right, and then the last thing that we looked at was the vasculature. Remember, I told you that the vasculature is also moving through the optic nerve, and that quite often you see a problem with venous engorgement. That is, the blood supply that's come into the retina having a hard time leaving the retina. And so we had Rebecca, who was an undergraduate in the lab, was directed by Michelle to basically measure the area of this vasculature that's running in the retinal ganglion cell area. And in fact, when you do that, count the number of occurrences that retinal ganglion cells are within these size ranges, so 0 to 100 microns, 100 to 200. And in fact, what you see is that the vasculature from the naive animal runs in the smaller size ranges, so 0 to about 300 microns, whereas the vasculature from the PHH model is running in the larger ranges, so 200 all the way out to 600 microns and even larger. So we are seeing an enlargement in some of the vasculature. We have plans to do more studies on that to see what's actually going on there. And is it found in just a region of the retina, or is it all over the retina, et cetera? All right. So in summary, then I'll just say that in comparison to naive rats, these post-hemorrhagic hydrocephalus rats have an increase in CSF surrounding the optic nerve, have an increased optic disc width in sections and OCT analysis. There's a decrease in the number of retinal ganglion cells, particularly in that area that is closest to the optic disc. And then we have an increase in the number of larger blood vessels, and the blood vessels also appeared to be abnormal. And we're kind of following up on that because many of the blood vessels appear to have this characteristic called tortuosity, which basically means they're no longer moving straight out to the edge of the retina, but they're kind of meandering a little bit, which is a sign of disease in the retina. In conclusion, I'll say that the post-hemorrhagic rats show many of the characteristics of the patients with hydrocephalus, and we're going to be continuing on and also characterizing the traumatic brain injury model system that the Hopkins people have developed. And I am happy to take your questions after the symposium. Thank you. Oh, and they disappear.
Thank you very much, Terry.
Yeah, I won't be able to find my pocket now. Here it is.
Thank you. Okay, our next speaker has a very unique perspective on hydrocephalus. Dr. Kyle Gospodarek, did I get that close? Graduated from the Indiana University School of Medicine in 2016. He's currently teaching at IU School of Medicine Northwest as a lecturer in clinical medicine. And his interest in medicine and in hydrocephalus began when he was 6 years old and had a cerebral brain aneurysm that ruptured and left him with an extremely complicated case of hydrocephalus. And I have to say that Kyle has on occasion texted me or emailed me from the emergency room saying that he was bored. He had nothing to do, right? You were bored. As this is a lifelong diagnosis that requires consistent intervention, Kyle has a unique perspective, and he's going to talk about both sides of the operating table. Thank you, Kyle. Let me just make sure that your slides are up here. If you turn it up. I'm going to do it on this side of the tie, if that's okay.
Oh, yeah, absolutely.
You'll
Awesome.
have to tell us from the back of the room if we don't have the mic just right.
Yeah, please do. Is that-
Okay, Lindsay. Smell. We don't seem to have the, oh, there
Oh,
we go.
all right. Good deal. Thank you.
Didn't press hard.
All right, and I apologize, my slides are a little bit out of context, yeah. The sizes of the pictures didn't go quite as planned, but nonetheless, as Bonnie said, my name is Kyle Gaspaderic. I'm an MD, but I teach as opposed to practice typically. So just a little bit about me. I did earn my medical doctorate in 2016. I'm right now working on my Master's of Science in Education. I ended up being fascinated by the field of education and kind of coincidentally started teaching at my home campus very serendipitously. Realized I loved it and it kind of just stuck with me since. And unfortunately, I have to say that I was wrong. And my mother, who has told me my entire life that I was going to end up being a teacher, was correct. And so I've got to give you this one. Nonetheless, also, I did earn a Bachelor of Science in Biology with a minor in chemistry from Purdue North Central, which is up in northern Indiana in 2010. And also, as Bonnie had mentioned, I did acquire hydrocephalus at age 6 after a brain aneurysm ruptured. Excuse me. And the location of the aneurysm was my right posterior inferior cerebellar artery. And that actually does come into play in a little bit, which I'll explain why. But the subarachnoid hemorrhage that resulted from that rupture ended up leaving me with both obstructive and non-obstructive hydrocephalus, which made it extraordinarily difficult to treat well. So I've had, including the ones from last month, which was the other time I was emailing Bonnie from the neuro ICU. I've had 56 surgeries total, and 44 of those were related to hydrocephalus alone. The others were random, kind of fun stories, but that's about it. Oh, sorry. So I did want to start with going over the ventricular system in general. I know this is probably quite a bit review for most individuals, but I figure it's worth mentioning nonetheless. So we do have 4 ventricles inside our brains that are filled with cerebrospinal fluid. We have our lateral ventricles, which are the larger ones on either side, our first and second, you could say. No one can agree on which is first, which is second, so we just call them the lateral ones. Then we have our third ventricle, which is here in the middle. And then this drains out into the fourth ventricle. And that fourth ventricle has outlets which allow CSF to leave the ventricular system and enter into the subarachnoid space surrounding the brain. So although there's, in typical situations, there's free-flowing communication between those two spaces, they do have somewhat different functions. The ventricular system has structures called choroid plexus, or as I like to jokingly call it, the nephrons of the brain, because it kind of are, they kind of are rather. Whereas the outside of the brain has arachnoid granulations, which are the places where that CSF is actually reabsorbed and put back into the venous system. And so both of these were affected by my type of hydrocephalus, my hemorrhage particularly. And going on into a little more detail about obstructive versus communicating hydrocephalus. So our obstructive hydrocephalus is something that's a little more direct, easier to explain, and I would argue in a lot of cases, easier to treat, at least surgically, because there is always there's typically a source that we can localize and identify where cerebrospinal fluid isn't making it past that point. And so everything proximal ends up dilating, ends up building pressure. So we typically treat that by either putting a catheter or shunt into any of those proximal spaces, typically the lateral ventricles, because as we saw, they're relatively large compared to our other options, and they are typically proximal to any blockage that does occur. The blockages will commonly occur along this long aqueduct, or sometimes in the outlets of the fourth ventricle, which was my case. Then we have non-communicating hydrocephalus, or I'm sorry, we have communicating hydrocephalus, in which case the problem isn't so much that the spaces aren't able to, or that the cerebrospinal fluid isn't able to flow from one space to another, but rather that there's either too much CSF being produced or too little being reabsorbed. A lot of times in post hemorrhagic hydrocephalus, we will see the latter of those situations occur, wherein the arachnoid granulations end up getting clogged with blood, clogged with debris, irritated, scar over, and then they aren't able to absorb that CSF as well as they should. And in those cases, it can lead to hydrocephalus that is rather difficult to treat in a lot of situations, which is why I was fascinated by Bonnie's work, because of the idea of modulating it with drugs other than acetazolamide. And so that's all I have for hydrocephalus in general. So I'll go a little bit into my specific instance. As I said before, it's rather complicated. I have been in pain in several surgeons' rears throughout my life. It's one thing I take pride in. So the subarachnoid hemorrhage that I had was quite massive. There was a lot of bleeding, a lot of blood in my subarachnoid space, which made its way throughout the ventricles to some degree, but mostly on the outside of the brain. And in doing so, it scarred up my arachnoid granulations, but it also scarred up a large portion around the foramen magnum and around the fourth ventricle. Remember, the fourth ventricle is that spot where that CSF would be allowed to leave the ventricular system and enter that subarachnoid space around the brain. In my case, it doesn't really have that opportunity. So that's how we ended up with both that communicating and non-communicating form of hydrocephalus co-occurring. Unfortunately, this did lead to longstanding hydrocephalus, which I anticipate I will have all of my life. And it also affects the treatment options in some cases, or in this case in particular, because things like endoscopic third ventriculostomies don't really work because they're only addressing one of my problems, essentially. So as I said before, the location of the rupture, the right pica, it led to the blockage of those outflows, the foramen of Luschka and Magendie. In my case, it also led to somewhat of a pseudo Chiari-1 malformation, in which case the foramen magnum itself was scarred over to such a degree that it restricted CSF movement from the brain space to the lumbar thecal sac. So because of this, I did have a propensity for developing a syrinx or syringomyelia, which is shown here. If we zoom in there, that white center, that's actually fluid, and it should be a spinal cord because that's a T2 weighted MRI. Fluid shows up white in those cases. And all of that should be filled with essentially gray. Instead, in that case in particular, the majority of my thecal sac was dominated by CSF, there was a very large dilatation within the central canal itself, which is a whole nother story that I don't think we'll be able to talk about today necessarily. Also, I developed slit ventricle syndrome, and that was a result of both the type of hydrocephalus that I had and the treatment that I was undergoing, which was shunting in the lateral ventricles. If you shunt too much, the ventricles can possibly collapse in on themselves. They become very small and eventually collapse in on the shunt itself, which obstructs it as well. So that opens up a whole new can of worms, so to speak. And so it did have some other lasting impacts. The main and the reason that I'm here with a lot of issues surgically is shunting. Shunting has both been a blessing and a curse of sorts. It's the only reason I'm here, absolutely. But it's also the reason that I ended up in the operating room 44 of those times. That's an overestimation, probably 30, 35, something like that. I have absolutely spent more nights inpatient in a hospital room than I have anywhere else other than my own bed. It's weird how it becomes familiar, getting used to that feeling of sleeping in your own bed again for the first time after a long stint in the hospital. And there's nothing quite like it, nothing I can really compare it to. It's absolutely magical. So you just kind of got to take the good where you can. And yeah, you do get bored when you're in there, especially as a kid. So they let me fish for things on, I'm still not sure exactly what I was doing there, but nonetheless, made for a fun picture. A lot of betadine. But something else that it did for me was made me very interested in the medical field in general. I half jokingly say pathologically, and you could make an argument for it being truly pathological. But I have been interested in the medical field to such a degree that I put my own health to the side sometimes, which wasn't exactly the best thing I could have done. Nonetheless, that understanding, that interest was how I essentially was trying to take control of what was occurring within me at that time. But along the way, I came to idolize a lot of my neurosurgeons, my first being Dr. Grant. I forgot to mention Dr. Bowman from Children's, that was Children's Memorial Hospital at that point. And then we have Dr. Iskander, my current neurosurgeon in Madison, Wisconsin. And then David Frim, who I will mention a little more in detail later, but he was probably the most impactful out of these. I also realized something else, being an observant kid that had nothing but time on his hands and no smartphones. So all I had to do was think and watch and just kind of, not much really. But one thing I did notice was the importance of everyone else on the medical team. I think any good MD knows damn well that nurses do a whole lot of the heavy lifting. And we need to treat them well and treat all of our other providers well, for that matter. So this goes on to my years of medical school, because that is the other side of my story here. Not only is it the hydrocephalus, but it is the fact that I was fortunate enough to be able to get my MD. I did matriculate into medical school in 2010. I was originally in the class of 2014. Unfortunately, due to a stroke that was incurred after taking step 1 of my boards, during a posterior fossa debridement of that scar tissue that I was talking about and removal of an aneurysm clip that was MRI incompatible, I ended up having a massive stroke and waking up not being able to feel the right side of my body. For those with the medical interest, it affected only the PWC ML pathway. So my pain and temperature sensation was left intact, which is odd, but it was a very clean delineation. Nonetheless, I did end up having to move from being right-handed to left-handed, which took some time. I took a year off, during which I did a whole lot of occupational therapy and physical therapy. And as it states here, my medical issues, not just the shunt-related ones, followed me into medical school. 20 of my surgeries of all those 56 occurred during those 6 years. And one could argue it was because I probably drove myself a little too hard in those situations. But for me, it was what kept me going. And so, not a great, I don't recommend it. I'll put it that way, but I understand it. One cool thing about medical school, though, was the opportunity to meet my regional class. And so being part of the Indiana University School of Medicine, shameless plug, at the regional campus, we have these nice small class sizes. My class was 26 students, and I got to know every single one of them very well. Whether that be going out after exams or sleeping on the floor during histology because we only had 2 weeks to learn the entirety of it. You do learn a lot about each other, and they provided an amazing support network for one, but also I had the opportunity to teach them a lot about my own ailments as they went, spanning from shunt-related ones to hernia repairs, appendectomies. I can't remember off the top of my head, but it was a neat opportunity for me. And they were able to ask me questions that they weren't able to ask typical patients, either because it would be rude to, or just pure interest, I guess. But it was fun. And I also had some really unique opportunities. One of them being during that hernia surgery, one of my upper classmates first assisted on that surgery. And then once I was able to continue on with my clinical years, I was able to rotate with with some of the surgeons that operated on me in the past. So it was really fun, to be honest. And so that picture became, call it pathognomonic for me. It was what a lot of people came to know me as, was just in a hospital gown with first aid in my lap, or another resource, but first aid was my go-to, if I'm being honest. Because it was just a nice distraction from everything. Having a lifelong medical illness it's rough. It takes its toll, but having something to drive towards, which in my case was that eventual medical degree, it was a good distraction, and it allowed me to fight a little harder. But on the flip side of that, my medical situation also gave me a little bit of distraction from my studies. So whether it's healthy or not, it was effective. I mentioned here, it anchored some of the concepts being learned because I was learning about a lot of things that I knew were wrong inside of me, so to speak. And then eventually I was able to diagnose my own genetic defect, which was a variant of Marfan's, C7702, but we'll talk about that later. Most notably, I was able to answer that nagging question of why me that I always asked myself in childhood. I figured that out, so that was very gratifying. But I did have to make a career pivot. After that stroke, I was left unable to do any real surgical options or anything too clinical. It was very difficult to be able to accommodate that, I guess you could say. And so when I came to enjoy teaching as much as I did, it just seemed like a very easy transition and a very natural one. So I mentioned my medical schooling, but I did a lot of my learning as a patient. I've been a patient a heck of a lot longer than I've been a medical student or a physician for that matter. All of my doctors were great mentors. They gave me a very unique perspective on medicine, one that you might not receive as a typical patient alone or as a typical provider alone. And they helped me make sense of it all, helped me deal with the enormity. One of those docs was David Frim. He was a neurosurgeon for, pardon me, a lot of my formative years. He recently passed this year, but for 20 years, he taught me, and he treated me like a resident. He taught me how to doctor early on in my career, one of the first to do so. And so he showed me what a doctor is supposed to be, how a doctor is supposed to act. But he also gave me a lot of hell too, in the best way, in the most kind-hearted way. A lot of medical students and doctors are familiar with the term pimping. He would do that mercilessly to me. One incidence of that was when I had a exaggeratedly dilated fourth ventricle and was vomiting daily in miserable shape on an exam table. He took the time to ask me what area of the brain was responsible for generating the gagging and the eventual vomiting. And luckily I was able to pull it out of somewhere because it wasn't in my actual brain space, but it was the area postrema. So thank you, Dr. Frim. And so throughout that time, I learned a lot about shunts too, a lot about hydrocephalus treatment options, essentially. And as I said before, I wouldn't be here if it weren't for them. So I have everything to thank them for, but again, they're not perfect. They cause a lot of issues. I included these pictures because my phone actually put this together on its own and assembled it like it was this fond memory, which I just thought was hilarious. But nonetheless, they were pictures of a superficial wound infection that ended up from tissue breakdown, which I'm known to break. My skin breaks down from dissolvable sutures. That's part of my FBN1 mutation. But as I mentioned here, we have several different ways that shunts can be problematic. Each one has serious consequences. And another situation that those with shunts and families of those with shunts have to consider is, what do we do if things go sideways, especially if things go sideways outside of our home environment? Can the helicopter land on the ship? Was a question that my mother asked when we were considering going on our first cruise. We had to have contingency plans. And it was accurate. We did, because if I ended up with an infection like I did a month ago, and that helicopter couldn't land, that I probably wouldn't be here talking to you today. So we do have to consider those things. And so our lives are a lot different because of it. I also did a medical mission trip to Haiti, which I still don't know how I got away with, but my parents were not the happiest about that one. But we figured it out. We figured out a way that I would be able to get to Miami in such a convenient time frame, so on and so forth. I'll leave it at that. So other than just the issues that I mentioned before, there are other morbidities. Revisions, as was mentioned, every shunt eventually fails. It's inevitable. Shunt infections occur in roughly 5% of revisions. There's a need for ICP monitoring, which is what you see here. That's a fun one. That was the first time that I emailed Bonnie from the neuro ICU, asking her if she had any work that I could do remotely. And then EVDs. You get real used to seeing your own CSF in a bag, which is kind of odd, but it happens. but it also gives us areas where we could work for improvement, right? We already talked about having shunts that would be able to clear their own blockages. That would be an incredible strain that would be taken off of hydrocephalus patients, because that would remove a lot of revisions from the situation. Also, if we were able to monitor for ICP within the device itself, it would be very helpful. Bacterial infection prophylaxis, of course, I know that comes with its own difficulties though. And then we've got more physiological means of CSF diversion, one of those being aqueductoplasty, which I learned about quite recently, but it's fascinating. So as a patient, one of the things that I have noticed as an area that we could improve is better transition from pediatric care to adult care. It's a very difficult thing for hydrocephalus patients to do that transition. And some of it's because our pediatric neurosurgeons only treat pediatrics. A lot don't. A lot will see their adult patients as well. But sometimes it's difficult to find someone that is willing to see an adult patient with hydrocephalus, because they're kind of few and far between. I shouldn't say that quite. They feel few and far between when you're looking for them, I guess. Which is something that as a provider, I think we can do better at too, is making ourselves aware or making ourselves available to those patients. So the thing that I am most excited about is the notion of our basic sciences, foundational sciences, and clinical sciences working together to actually have a better treatment option that we might be able to meld some of our surgical maneuvers with CSF modulation in either production or absorption. Individuals who are much smarter than me in those areas, I'm going to pass that buck to, but I have faith very much that we'll get somewhere. And so as my last slide, if you do have any questions, as we mentioned before, my email is here. My cell phone is also here if you'd like text or call. Other than that, thank you for your time. And
Thank you very much, Kyle. We're now going to take a short break. We're going to stay on schedule by starting again at 3:15 because that's what's on the schedule. So 20-minute break. Again, for those of you who might have come in later, if you go straight down the hall here and take the first hallway on the left, there you'll pass the elevator, and the restrooms are just on the other side of that. And we'll see you back here at 3:15. Thank you.
Hello, I don't hear anything from your end. Which might be a bad sign. Can you hear anything that I said? Ah, I see a hand go up. Excellent, excellent, good. That sounds good. Ah, there's a break.
Work? Can you hear us now?
I can.
Oh, it's the microphone.
So,
So Dr. Schiff, you're gonna go right after Dr. Taylor. And I will make you a co-host so that you can advance your own slides from your computer.
yay, thank you.
Okay. You're welcome.
And so we will start at 15 after the hour.
Correct. We'll start, Dr. Taylor will speak at 3:15 to 3:30, and then you are next.
May I just test to make sure if I share these slides with you that everything looks proper on your end?
Yep.
Yes.
I made you a co-host,
Yep,
so go
you're a
ahead.
co-host.
I feel the power surging. Let me try the way that probably won't work. Do you see the full
Yes,
slide,
you do. Yep.
or do you see the presentation notes?
Now, we see it with your slides on the side.
Oh, that's not going to work. Then we will try plan B.
We should be able to go to presentation mode though from there.
Yeah, from where you were.
Yes, I know. There was strange things today, and at NIH, it was really strange. I can't explain it. Do you see a regular?
Oh, perfect, perfect.
All right. You don't see notes or slides on the side. You just see a full
Right.
screen of the
You
slide.
just see your whole screen.
And you see a second slide.
Yep.
Ah, wonderful. Thank you. I have, I'm all technically good to go. I'll see you guys at 15 after and look forward to the talks.
Thanks so much.
You bet. Bye-bye.
works. All right, let's get on with the second half. So Kyle, where's Kyle? Is he here? Or did he leave? That was a very inspirational talk. Your journey was obviously something that you spoke from the heart. And I think the slide on what we need to do to improve is all valid points. And I think the part of this process is that shunts will always be around no matter what we do in terms of having medical therapy too. So we need to do both of them right. So, well, it's a pleasure for me to introduce the next speaker, Jignesh Taylor. He's an assistant professor of neurological surgery. He joined our department in 2021, and he'll soon develop, I believe, an independent laboratory focusing on neural stem cells and the origin of childhood brain tumors. He completed his fellowship training in pediatric neurosurgery at Johns Hopkins. Actually, Dodie Robinson's husband or partner is his mentor. And he completed this training in 2021 and he received his medical degree from University of Oxford. And he holds a PhD in stem cell biology from the University of Cambridge. And then during his neurosurgery training in London, he received the highly competitive Wellcome Trust Postdoctoral Research Award that allowed him to complete a neurosurgery training at the University of Toronto, doing an unfolded postdoctoral research fellowship at Hospital for Sick Children in Toronto. And that was with Peter Dirks, who's a world leader in brain cancer research. With regard to his work on hydrocephalus, he's the site PI for our hydrocephalus research network, and he's developing a non-invasive monitor for infants at risk for developing symptomatic hydrocephalus with collaborators at Purdue. And he's looking at AI and machine learning algorithms to predict whether to shunt somebody after IVH or prematurity. So Jignesh, thank you.
Great. Well, thanks so much. Is this better? How about there? That's better. Okay, awesome. Well, thanks so much, Dr. Shah, and thank you for inviting me here to give this talk. I get really excited when I'm in an area where there's so many different disciplines, because I really believe that that's when innovation occurs. It's when you have the intersection of all these different disciplines and different perspectives coming together. So this is really, really fantastic. Thanks for having me here. I'm going to give you a perspective of pediatric neurosurgery, because that's what I do. Slight disclaimer, I'm not a hydrocephalus researcher yet, of course, as Dr. Blasio said, anything can happen and careers can take a turn. So I invite, any ideas for collaboration. And obviously my background is in stem cell biology, and I have an interest in harvesting neural stem cells from brain that we can access as neurosurgeons, and some of these can be important cellular models for different types of diseases. So obviously, as a pediatric neurosurgeon, we're at the forefront of managing hydrocephalus. These scans are not unfamiliar to us, and we've heard, obviously a remarkable story from Kyle, and thank you for sharing that with us today. This is a 3-year-old that I had the honor of looking after this week. And the first scan here is a CT scan that shows the brain. And these areas here are the ventricles, which you can see are blown up. They're very, very large. And we can tell that there's pressure there as a result of hydrocephalus, because there's transependymal edema as well. And here you can see in the posterior fossa a mass, which essentially is obstructing the flow of fluid. So hydrocephalus is a problem of fluid dynamics. You have raised pressure, you raise volume, and as a result, abnormal brain function. That's probably a very simplistic neurosurgeon's view, because obviously there's a lot more to it, and you can have hydrocephalus with normal pressure as well, as we all know. But essentially, it's a problem of fluid dynamics. And here, unfortunately, this MRI shows a brain tumor, which is obstructing the flow of fluid. And as an emergency in the middle of the night, we had to place a drain called an external ventricular drain in order to help the poor kid survive. And so once we do that, we can kind of relax a little bit because the pressure's controlled. And then the next step would be to tackle the cause of the hydrocephalus, which of course, in this case, is the brain tumor. And he had a resection on Wednesday and is doing really well today. Here's a overview of our operative volume for hydrocephalus at Riley Hospital for Children. On average, as you can see, we're doing about 200 operations for hydrocephalus per year. And that's, both shunts as well as drains and endoscopic third ventriculostomies. And as I mentioned, hydrocephalus can occur due to a number of different etiologies. And tumor is just one of them, but of course, there's so many others, that causes hydrocephalus in many different ways. And as Kyle mentioned, we tend to classify them as those that cause obstruction to the flow of fluid and those that don't have a clear obstruction. And there might be some other mechanisms involved where we don't understand. For example, there's a lot of studies now that show abnormal cilia function in the ependymal cells after post-hemorrhagic hydrocephalus, something we hadn't really thought about. And so again, cellular models are really important in those situations. But yeah, there's so many different etiologies. In terms of demographics, there's a number of different ages, and most of them, of course, are young. They're neonates or infants, but we also do operations in teenagers, of course. So, as Kyle said, this is a lifelong disease. It's something that unfortunately we have to continue to operate on and reoperate on and address as the child grows up. Here's an overview of the types of surgeries that we do at Riley Children's, and this is most of them are shunt surgeries, either initial shunt operations or revisions. And here's a schematic diagram of a shunt, and you can see a tube going into the ventricles of the brain, and that gets connected to a valve, which is connected to a tube, which is tunneled all the way down into the belly. And so the idea is that the valve controls the pressure inside the head, and when the pressure rises as a result of abnormal absorption or obstruction, the excess fluid can come out and be drained down into the belly and be absorbed there. So the other place that we usually place shunts is in the heart. In the atrium here, the pressure inside the atrium is typically low, and so we can that's another site where we typically will put shunts if the abdomen is not accessible to us. But as we've seen, there are problems with shunting, and the biggest problem is the risk of early failure, and that's not small. It's 50% in 2 years. This is a study, probably one of the largest studies that came out of. Oh, can you hear me now? So this is one of the studies that came out of Denmark, and it's a 40-year experience of shunts, and showing the failure rate, which is approximately 50% in 2 years. But that's not the only problem, as you've heard. Infection occurs in about 3%. As children get older, that hardware can break. It can disconnect because the child is growing, and the catheter gets stuck at certain points where there's scar tissue, and so that just tugs on the catheter, and it's not uncommon for us to see it snap or disconnect at the connection points. And then, of course, over drainage. A shunt is not a physiological system, although we try to make it as physiological as possible. And so there's always a risk of us draining more fluid off than we really need to. Or the child can grow out of the problem, and yet, you still have this drainage when they're exerting themselves or whatnot. And so that can cause over drainage. And then, of course, there is some sort of stigma attached to it. Now, I always tell my families and kids that a shunt is not a marker of anything. You can do anything you want with a shunt. You can live a normal life. You can play sports. You can play football. It's, of course, there are risks of breaking a shunt, but then there are also risks of breaking your bones when you do stuff. So I don't know if a shunt, strictly speaking, needs to stop kids from being kids. So the alternative is a procedure which we touched on before. It's called an endoscopic third ventriculostomy. And this procedure, has caused a lot of excitement in the field because, as pediatric neurosurgeons, we don't like, dealing with shunts, right? And this is quite a nice operation because it gives us very good anatomical views, and it can also be very effective. So if, for example, there's a obstruction to the flow of fluid, say at the cerebral aqueduct, say for aqueduct stenosis, well, the idea behind this treatment is that, well, we don't need to worry about that. We just bypass the obstruction. So we will make a hole or a fenestration here at the floor of the third ventricle, so that when fluid falls down into the third ventricle, instead of going into the cerebral aqueduct, it just goes down this new hole that we created, and then circulates around the brainstem and then to the arachnoid villi. And so that is the principle behind endoscopic third ventriculostomy. And there's also been a lot of research now that's been occurring by Dr. Kulkarni and John Kessel and others in the HCRN about this the other half of the procedure, which is called a choroid plexus cauterization. And essentially what the idea behind that is that if we also at the same time coagulate the choroid plexus within the ventricle, then we might be able to, decrease the amount of CSF production and therefore help with the hydrocephalus in that way as well. But there are factors that affect ETV success. And one of the biggest problems with the procedure is that it usually doesn't work very well in neonates and kids less than 1 year of age. As you can see, this is a really nice predictive model that came out of Sick Kids, Dr. Kulkarni here and Dr. Drake and his team put this together in 2009. And it shows that, the success of an ETV can be calculated by the age, the etiology, and the previous shunt. And for each of these things, you assign a score, and the total score that you get is equal to the percentage success that you get. So the older you are, the greater the chances of success. And the etiology matters too. So if there's obstruction to the flow of fluid, then it's more likely to be a success. But for the other etiologies like interventricular hemorrhage or infection, where there's a lot of scarring, a lot of scar tissue, it may not be as effective. So there are problems with ETV CPC as well. And there are also anatomical limitations. We can't always get inside the ventricle. If, for example, the pressures are high, but the ventricle is actually pretty small, then it's a very challenging operation to do. There's a learning curve associated with doing this because it's an endoscopic procedure, and choroid plexus cauterization as well is tricky and often requires the use of flexible endoscopes, which not everyone is trained to do. And the other thing that people have noticed or questioned really is, what about the cognitive outcomes? Because the one thing that we've noticed is that after endoscopic third ventriculostomy, the ventricles don't tend to go down as much, so they tend to stay big. But the pressures seem to be controlled, and brain function seems to be, better. So what's not clear is whether that ventriculomegaly or persistent ventriculomegaly is relevant or not. And so people are looking at whether it's better for cognitive outcome. That leads me nicely to the ESTHI trial, actually, which is a big multi-center randomized control trial that is spearheaded by the HCRN, which is the Hydrocephalus Research Network. And it's really looking at ETV CPC versus a shunt in children less than 2 years of age. And their primary outcome measure is neurocognitive testing. And so currently this is, a trial that is open to the HCRN member institutions only, although there is a strict criteria for, joining this in terms of, how well-trained the surgeon is and the volumes that we're doing. And recently, Dr. Kessel reached out to us to say that they were struggling on recruiting patients in this trial and wondered if we could participate. And so once, I hit 10 ETV CPCs, we'll be able to hopefully join that trial, which is exciting. So just a quick word about the HCRN. Obviously, I am assigned lead for this, and that's because we're not part of the HCRN membership, but we are part of the implementation arm. So they have an implementation arm, which is called the HCRNQ, and that was really put together in 2020 around that time, when they wanted to essentially have other centers that could help provide data, and also they wanted to then provide suggestions that, based on protocols that they were using within the HCRN. So we joined the implementation arm in 2020. We were the 5th site to join, and we contribute approximately, nearly 10% of that patient volume. So we do have a considerable volume. We obviously have a history with the HCRN. Tom Lewison in 2006, when he was here at Riley, was one of the first to actually set up the HCRN with John Kessel, and then obviously took the membership to test his children. So it is a membership for the institution, and not not for the surgeons per se. Okay, so but I think this is a great platform for us to, let's say, collaborate and also to be part of, because we are interested in doing some clinical studies here, of course, and anything that requires a lot of patient recruitment is always best done with multi-center trials. And this is one example of a study that we're starting at Riley. This actually began as a senior design project by the undergrad engineers at Purdue, and I got in touch with one of the guys who runs that program and said, hey, we have an idea here, because assessing hydrocephalus in babies and neonates can be pretty challenging, and it's difficult to know sometimes whether they're truly under pressure or not, because they have a soft spot here, but it's very subjective. Like, you kind of feel their head and see whether it's under pressure. We also look for suture splay and the expansion of their heads, but there isn't really any objective way to measure. And so I mean, this has been looked at before by many different groups, but when I talked about this problem, they mentioned that there was actually a group in Purdue that had come up with a sensor for the eye. It was like to measure intraocular pressure, and they wondered whether that might work if you placed it on the fontanelle. And so we trialed it with a senior design team, and one of our residents, Andy Witten, who was actually a Purdue grad, he was interested in taking this forward. So now we're at a stage of trialing this in babies. We just got our IRB approved for it, and hopefully we'll get some interesting readouts, but more to come on this. But as a sort of stem cell biologist, I guess one of the questions that I've always asked and wondered is, well, why do ETV CPCs fail in young neonates? And what is it about their ventricular system that is different or not different? I mean, we have no idea, really. There have been some theories as to why they fail. Some people argue, well, their absorption system is just immature. So even if you make a hole and allow fluid to circulate, they don't have a way to absorb the fluid. through the arachnoid villi, and so the ETV is never going to really work. And that's true in some cases where, you have someone who comes back with ETV failure, and you see that the hole that you've made is still there, it's open, but they've failed. And so that suggests, of course, that there are other things at play. It wasn't just the obstruction. But that's not always the case. More often than not, you actually see that hole close up, and you don't see the flow that you can detect on an MRI scan. And I've always wondered why that occurs in young, children. Is it due to scarring? Is it just scarring? And sometimes it kind of looks like scarring when you go back into the ventricle and look at it. Or are there other things at play, right? We know that the ventricle is lined by neural progenitors. I mean, that's a germinal zone. There's a subventricular zone that has neural stem cell populations, which obviously do diminish with age, and in adults are not really active, and we don't really understand what the function is. But in the neonates, they may have a function. They may have a healing function. And they may be recruited to these areas of injury through pathotropism and other ways to cause that hole to close up. And so it might be interesting to study this. And so one way that we could try to understand a bit more about the human ventricular system and the cells that are lining both the lateral ventricle as well as the third ventricle is to collect tissue, and to look at that through histology, through sequencing and spatial transcriptomics, to try to understand, well, what are these cells that are there in early stages but not later. And so this is an IRB that we just got approved to try to collect tissue from the ventricular wall during intraventricular neurosurgery. So for example, sometimes when we have to operate within the ventricle, we use tools such as the brain path or other tubular retractors to get us there. Now, as we're going through, there's always the wall of the tissue that comes off. I mean, in fact, a lot of times we have to just, actually go through it with a sucker, and that tissue is just, goes up in the sucker. Well, actually, this instrument, the Myriad, is a really neat aspirating device that also helps us collect tissue. So you can aspirate the tissue that you don't need or you need to get rid of in order to get access to where you want, but at the same time collect it and harvest it for research. And so this was an idea. I'm putting together a small seed funding grant, which NICO Myriads have, to try to get us started to see what type of tissues can we see if we collect tissue in that way. And part of that will also have ependymal cells. And so if there's an opportunity here for people interested in ependyma to collaborate. So I'll stop there, but I really do want to thank Bonnie and everyone here for inviting me today. That was a pediatric neurosurgery perspective. There's a lot more research going on the adult side, as Dr. Shaw mentioned, which I haven't had the time to discuss. This is our pediatric neurosurgery group led by Dr. Ackerman. There's Dr. Kezer, Dr. Wilson, and myself. And of course, I want to thank Mitesh and Mariah Sherrill, who's our research coordinator, who's kindly helped give a lot of the data here. So thank you.
Thanks, Jignesh. Our next speaker is Dr. Stephen Schiff. He's a professor and vice chair for global health in the Department of Neurosurgery at Yale University. A pediatric neurosurgeon, he's got an interest in neural engineering and sustainable health engineering. He received his NIH Director's Pioneer and Transformative Award in 2015 and 2018, respectively. He's been working on disseminating a low-field MRI technology in low-resource settings, and this has led to the discovery and characterization of neonatal pan-bacillus, a new disease syndrome that is an important cause of infant sepsis and hydrocephalus in East Africa, and he's connected by Zoom here.
Well, thank you very much. Can you all hear me okay?
Yes.
Wonderful. So I really appreciate the opportunity to be part of your symposium today. And we think globally that there may be as much as 400,000 new pediatric cases of hydrocephalus each year. The vast majority of those cases are in the developing world. The greatest concentration of cases is in sub-Saharan Africa, and the largest contributor to those cases is following infection. So at this one site in eastern Uganda, the Cure Children's Hospital, since 2001, they've treated over 13,000 infants and children with hydrocephalus. Over 8,000 are post-infectious, and essentially all have been culture negative. As Dr. Taylor just showed you, if you put an endoscope into the third ventricle, our preferred way of trying to treat these children, then a typical appearance, I hope you can see my mouse here, a typical appearance will show an array of small pustules adherent and lining the ependymal surface in the ventricle. Often we come through the floor of the ventricle, as he described, and you see a relatively pristine space that doesn't look like it's had an infection before. We see this appearance in these children in East Africa, but if you walk into an operating room in Hanoi, you'd see often a very similar picture of adherent pustules, and my colleagues have seen the same thing in Haiti. It's a global phenomenon that we've not understood much about. I visited this hospital first in 2007, and I was interested in trying to do something helpful. I asked Ben Worf, who was the medical director at the time, what was the most important project I might be able to work on that they needed help with? And he said, well, maybe I could figure out what makes these kids sick. And I thought, how hard can that be? As a child, I had leafed through my grandparents' edition of the well-known De Kroof book on microbe hunters, and I figured, you bang on doors, you find people who know something about infections, and you figure out what the cause is. I'm here 16 years later, finally able to answer some of those questions. And our big break came with very substantial support from the NIH Director's Office. Solving this required a level of resource commitment beyond what we were able to ordinarily secure. It enabled us to use very high quality technologies for both for preserving these specimens on site at multiple places in Uganda. We set up a cryogenic infrastructure that was robust against the insecure electrical grid using liquid nitrogen. We used large commercial dry shippers and managed to ship over 8,000 frozen tubes without losing any to thawing from Africa to the United States. So what do you do if you're faced with children that have the clinical symptoms and signs of infection, but you can't grow anything, and you have nothing that comes up positive on your standard infection panels? Well, you can amplify a gene from bacteria, which humans don't have, and identify at least the genus of bacteria through sequencing that gene. But to identify viruses, fungi, and parasites, we've turned to deep RNA sequencing. And by 2020, in 100 post-infectious and congenital hydrocephalus patients, we use congenitals as controls, we started finding that one organism seemed to dominate these infections. It was a Panibacillus, which is Greek or Latin for almost a bacillus, a genus that was described about 20 years ago and broken off from the bacillus family. It forms a highly destructive infection in the brains of these children. Here's a typical appearance with multiple calcifying abscesses. Everything I'll show you now will be on infants under 90 days of age. And it was extremely difficult to grow in culture. This species was Thiaminolyticus. So Paenibacillus thiaminolyticus has been known since 1950 or so. It was first found in the gut of humans in Asia. It was not known to be a pathogen. If we place that reference strain into mice in their peritoneum, they don't get ill. If we take the African strains of that same species, they're dead within a day or two. We managed through over 1,000 different types of cultures on hundreds of these specimens to finally get 3 strains to grow. We assembled their genomes. We looked at their antibiotic sensitivities and resistance patterns. These organisms have picked up multiple antibiotic resistance genes. They also have picked up, in contrast to the reference strain, a type 4 pilus system. That's a little hair-like secretion system which helps certain bacteria form biofilms and adhere to things. And it is one of the virulence factors of Neisseria meningitidis. We are working below the meningitis belt that goes across Central Africa. We're about 200 kilometers below that. But the bacteria that we've found here shares a virulence factor with that organism, which is also highly neurotropic. If we CRISPR edit out that type 4 pilus system, the organism loses much of its lethality. But now that we've identified this, there are many unanswered questions. We don't know when this infection was acquired. We don't know if it even caused the hydrocephalus. It could be a secondary infection. And how do you solve this? Well, most of the mothers would report to us that their infant was born without a large head, had a very serious febrile illness, often with shaking and jerking of the limbs, suggesting seizures in the first few weeks of life. Then after the child had survived that, the head began to grow. If this sounds like neonatal sepsis, and worldwide neonatal sepsis is still killing upwards of 1 million infants a year around the world. That's many more deaths than are attributed to malaria of any age. I've testified to Congress about this situation. We don't know what causes most of the cases of neonatal sepsis worldwide, and we've ignored it as a medical community, both from research and funding agencies, as well as government and World Health agencies. As I mentioned in my testimony, newborn infants dying in the developing world have never had a political voice. More recent wonderful studies, I especially like the Cambodian study and the ANISA study, the large South Asian study, with very, very good quality, are still identifying perhaps 2% of the putative pathogens in global sites for neonatal sepsis. So what did we do? We set up 3 linked simultaneous case-control trials in Uganda, 1,400 subjects, over 8,000 samples. We then confirmed with both genus and species this particular bacteria using over 2,500 qPCR reactions. This just came out in the Lancet Microbe. And so we work backwards. We start from hydrocephalus. We know that a lot of them may have come from neonatal sepsis. Many children with sepsis have a perinatal transmission. We're also concerned with environmental sources. So let's start by comparing post-infectious hydrocephalus and congenital hydrocephalus without a history of infection. Almost half of these post-infectious cases are PCR positive on admission for Panibacillus. We ran a maternal trial, and this is laboring mothers giving birth both in the east and the western regions of Uganda. Half of the mothers were septic at the time of presentation. Not a single DNA read to Panibacillus in samples from their birth canals, placenta, maternal blood, and cord blood. Let's look at neonates with sepsis. 6% of 800 patients with samples of blood and spinal fluid from east and west in the country were positive for Panibacillus as a cause of their infection. Here's one piece we were really looking for, was linkage. Could we find neonates with sepsis that recovered from the sepsis and then came back with the same infection with hydrocephalus? These are two cases. They're 1-week-old infants. Note in this child who has both 16S evidence and then confirmatory PCR evidence of Panibacillus thiaminolyticus. Note the little cyst in the frontal lobe when septic. This child gets 3 weeks of ceftriaxone, which turned out to be a very good choice for this organism based on laboratory sensitivity. Child is afebrile, feeding well, looking alert, goes home, comes in a month later with substantial hydrocephalus. And now note that that small cyst has turned into a maturing, calcifying abscess in the frontal lobe. PCR again confirms the presence of the same organism, which was not sterilized in the nervous system on 3 weeks of antibiotics. Here's another case. This child has extensive white matter destruction, comes in at a week of age, again 3 weeks of ceftriaxone, returns 3 months of age with heavily destroyed frontal lobes. Note the increased density of this lobe. This child also remains PCR positive for Panibacillus. So then we looked at the disease syndrome in the neonates. And we've named this a new disease syndrome. There's really no literature on this at all. We call it neonatal panibacilliosis. It is a very virulent infection. 14% of those children went on after treatment and survival to get post-infectious hydrocephalus, almost unseen in any other organism causing neonatal sepsis in this cohort. But it's misleading. You have to survive in order to get post-infectious hydrocephalus. More children died during excellent treatment than went on to get post-infectious hydrocephalus. So it's a highly lethal and very and destructive infection, both of the brain and of the lives of these children. We just reported this in Clinical Infectious Diseases. There's a very nice editorial by Michelow and Obara in that same edition of the journal, talking about the critical need for better tools for us to diagnose and understand neonatal sepsis. And then it turns out you have to know the PCR status at surgery. We either do shunts, as Dr. Taylor said, or we try to do endoscopic surgery. Look at the results if you're PCR positive of the ability of the diversion procedure, shunt or ETV, to function. If you're PCR positive, it destroys the function of the endoscopic third ventriculostomy. So we have to learn how to treat this at the surgical site when patients come in for care of their hydrocephalus. Most recently, since we've been publishing about this organism in Africa, we're getting multiple case reports appearing now in the United States. Same organism. It's Panibacillus thiaminolyticus for the ones I'm showing you here. There are a few cases of a related species, Dendritiformis. These cases have the same destructive brain appearance that we see in the African patients on the top row, These are US patients in the last 2 years, and most of the US patients, despite good US care, have died as well. Going forward, how do we handle such things? So we know a lot about the patterns in Africa, but I've just spent years, seriously years, giving you the molecular diagnostic conclusions from these 1,200 patients. So with support from the NIH Director's Office for what I called predictive personalized public health, we're trying to look at the patterns to give us a better way at point of care to create our differential diagnoses and better treat these children. Here's the spatial concentration of where post-infectious hydrocephalic cases are coming from in Uganda. This is over 4,000 geolocated cases. Here's Lake Victoria. These are the northern banks of Lake Victoria, a very swampy, wet area in a plateau. This is Lake Choga, where the Nile flows in and then out of, again with huge swamps on the southern and northern banks. And this is where this organism is concentrated, as well as piling up against the Kenyan border. We've taken all 60,000 villages in Uganda and placed them onto the satellite climate grids. We're looking at vegetation indices, and I'll explain that in a minute. If we look at the rainfall in each patient's village when they're born and then go backwards a year, what we find is there's a tremendous association. When the rains come in just before birth, this organism becomes a high risk for these infants. This is a village, Kihadi, in eastern Uganda, where one of our patients had come from. Dr. Malando here and I are spending a few hours talking with the villagers, trying to decide as soon as we get our approvals, which we're starting to get in now, how we're going to conduct the field work needed to identify this organism in the environment. We've worked very hard with our African collaborators and stakeholders to negotiate a genome and data sharing policy. One of the things we've done with this is looked at the ancient migration patterns into this area of Central Africa. Really, there's two large migrations that contribute to the population in the modern nation state of Uganda. There's a Nilo-Saharan migration up to about 1,500 years ago. And then there's the Bantu expansion from Southern Africa, which came in starting about 5,000 years ago. If you do whole genome sequence analysis of 1,000 of these infants, you see these migration patterns readily evident, painted onto the geography of the country. We're presenting this today at the Human Genetics meeting in Washington, D.C. So here's the rainfall pattern for post-infectious hydrocephalus. Spina bifida is the next most common source of hydrocephalus in this population. Look, this is individual village averages for rainfall. The children with infection come from wetter villages compared to the children with spina bifida. There's no association with spina bifida at the time of birth, but we're vigorously looking at other correlates that may have a role. Vegetation for a nutritionally sensitive malformation, spina bifida, the poverty index, and interestingly, there may be a link to ancestral admixture. Now, most brains don't have access to imaging around the world. We have placed a low-field commercial MRI scanner at the hospital in Mbali during lockdown. Most recently, we've done an assembly of what we think is the next generation of such sustainable low-field imagers. This is an engineering group that I collaborate with in Mbarara, Uganda. This was recently written up in both Nature and Science, and we recently wrote a nice review of this type of next-generation technology. What do you use it for? As Dr. Taylor very nicely told you, an endoscopic case can leave you with large ventricles. These are two post-operative cases. And usually we look at the thickness of the mantle to determine if we've decompressed the brain well, but it can be very misleading. This child has a small brain, and this child is not doing well on developmental testing. This child has a brain of almost normal size, riding on those larger ventricles, and this child's development is almost normal for age. So we drain fluid, but we're in the brain growing business. And there is beautiful old data looking at how the growth of the brain relates to body size. That's called allometry, the different proportions of the body, and it has a very unfortunate history. Paul Broca, whom some of you recognize as a neurologist in the 19th century, did a lot of work on this. He was doing it for some motivational reasons that were based on both looking at males versus females and different nationalities in Europe to prove who might have been best. Stephen Jay Gould wrote a wonderful book about this and looked at Broca's data. We looked at over 1,000 scans of normal North American children. Broca's difference in brain size between normal children and then young adults is easily seen. Gould's difference, looking at normalization of brain size by body size, is still reproduced here. Unexpectedly, we found that the ratio of brain to fluid in the normal child is very tightly regulated. We don't understand what does this, but you don't have to look at whether a child is male or female or large or small. That fluid, which is floating your brains right now while you listen to me, is extremely tied to the actual size of the brain throughout the growing child's life. So we've put together normal brain growth curves for the normally developing child, and we use those curves in our clinical trials, our randomized trials of surgical techniques for hydrocephalus to ask how well we're doing in managing that brain growth. We do this in our ongoing randomized trial entering its 10th year of follow-up in Africa. And as Dr. Taylor mentioned, we're part of the ESTHI trial, and we're also using brain growth as a metric for success in the North American ESTHI trial. We're putting technologies for imaging into parts of the world without any radiologists. So we're trying to embody the expertise of a radiologist into a variety of advanced machine learning algorithms to be an assist for the physicians on site with these new imagers. And nobody does this alone. I've had the tremendous privilege of working with some of the best people on earth who've joined us to try to help these kids. And they've really poured their hearts and souls into this. And everything I've told you today has been supported strongly from NIH. So I'm delighted to answer some questions. I really thank you for your attention today.
Steve? Oh, could you, Dr. Schiff, stop sharing, please?
Yes, I can.
So we're going to go from the swampy banks of Lake Victoria in East Africa to the banks of the White River here. Our next speaker, Dr. Majmouder Sheth, is an assistant professor of pediatric neurology here at Indiana University School of Medicine and Riley Hospital for Children. She completed her medical school at the University of Cincinnati College of Medicine in 2013 and her postgraduate residency training in pediatric neurology at Washington University School of Medicine in St. Louis and the St. Louis Children's Hospital in 2018. She's a board-certified neurologist with special qualification for child neurology, and she subspecializes in neonatal neurology. With this, she does both prenatal and fetal consults with our OB and maternal fetal medicine team, and as well as our neonatal consults within the NICU. and she follows these infants in early childhood period in the outpatient clinical track neurodevelopmental outcomes. Welcome.
Okay. Can you hear me? Yes, no? Can you hear now? Okay, just move ahead. All right. So yeah, thank you so much. So as you heard, I'm a neonatal neurologist. So that involves seeing consults on the prenatal side, as well as neonatal side in the NICU. So these are some of the most common causes of hydrocephalus that we get consulted for. On the prenatal side, most commonly we see congenital aqueductal stenosis, and a little bit less commonly genetic cause with X-linked hydrocephalus. And then on the neonatal side in the NICU, most common cause we see is post-hemorrhagic in the premature babies who've had intraventricular hemorrhage. And as you can imagine, we're talking about neurodevelopmental outcomes. Those are going to vary depending on the cause. I would say the great majority of patients that I follow in clinic that have hydrocephalus are going to be post-hemorrhagic due to IVH in the setting of prematurity. So in terms of looking at the outcomes today, I'm going to focus on that neonatal period and post-hemorrhagic hydrocephalus. So we've already heard a little bit earlier this morning about IVH and post-hemorrhagic hydrocephalus. So just to give a little bit of a review, IVH is clinically graded from 1 to 4, and the higher grades 3 to 4 are more likely to be associated with post-hemorrhagic hydrocephalus. And we see this in about up to a third of preterm infants who have IVH. And so in terms of thinking about this, once you've had IVH, there's been injury to the brain tissue. So trying to piece out in terms of the outcomes, how much of that is related to injury from the IVH itself versus the hydrocephalus can be a little bit difficult. But there have been studies looking at post-hemorrhagic hydrocephalus in and of itself, and it's associated with poor outcomes than in those patients that have IVH and don't develop hydrocephalus. So it's thought that hydrocephalus kind of further exacerbates injury that's already there from the IVH in the developing neonatal brain. And a lot of this has to do with white matter injury. So when you have white matter injury in the setting of IVH, you tend to have poorer outcomes than if you've had IVH without it. And in patients that have post-hemorrhagic hydrocephalus, they tend to have more white matter injury. And so it's thought that the white matter injury is what contributes to those worse outcomes that we see in hydrocephalus through inflammatory and other damage. And when we look at patients who have IVH and post-hemorrhagic hydrocephalus, increasing ventricular size adversely affects outcomes. So there's a study that compared those that have high-grade IVH 3 to 4 that did not develop hydrocephalus versus those that developed hydrocephalus that did not progress and did not need any surgical intervention to those that developed progressive hydrocephalus and then eventually required surgical intervention. And those that required intervention had worse outcomes in terms of motor, cognitive, and language at 18 to 24 months. And progressive hydrocephalus that ended up requiring surgical intervention were the most adversely affected out of all of the groups. So in terms of thinking about the outcomes, there can be effects on motor. So motor delay, impaired mobility and ambulation, so things such as cerebral palsy, cognitive dysfunction, so intellectual disability, behavioral issues, which can include autism, and then sensory dysfunction with vision and hearing impairment, and then of course seizures and epilepsy. And there's a study that looked at children aged 4 to 12 years who had had hydrocephalus as infants, and about half of them had learning disabilities, about a third had CP, and then a third had epilepsy. And in terms of looking at the different causes of hydrocephalus, those that have post-hemorrhagic and genetic causes tend to have the most adverse outcomes compared to other causes, including tumor, trauma, infection, et cetera. So this was a study that actually got published earlier this year from China and looked at infants who had had post-hemorrhagic hydrocephalus with a median follow-up time of about 3 years. And the kind of mild, moderate, severe deficits that are listed here are based on a standardized score called the Pediatric Stroke Outcome Measure. And this looks at motor function, sensory function, language, cognitive, and kind of breaks it down. And that's how they created these kind of level of deficits with mild, moderate, and severe. And so we can see that there is a difference when you see white matter injury versus not seeing white matter injury. So this second column here is those that had white matter injury when looking at MRI. And those had more significant deficits compared to those that did not have white matter injury, which is the top here on their MRI. Which goes back to what we talked about earlier, that it's thought that it's this white matter injury that results in these more adverse outcomes. And this was done out of China, so there can be some variation if we look at different countries, but I think that the overall kind of message here is that a good chunk of patients who have post-hemorrhagic hydrocephalus do tend to have significant disability. And even those that didn't have white matter injury, more than half of them had moderate to severe deficits. So there's a post-hemorrhagic hydrocephalus workshop that was held at the NIH several years back. And they actually published a paper looking at kind of different opportunities for research. And one of those sections was looking at improving outcomes. And this is a few years old, but these are some of the things that they thought of in terms of research opportunities to improve outcomes for the future. And I wanted to go over a couple of patient cases. So this first one is GH. He was born at 25 weeks, had bilateral high grade 4 IVH, developed post-hemorrhagic hydrocephalus, had a VP shunt placed. He did have seizures when he was in the NICU, and he does currently have a diagnosis of epilepsy, but he's only on 1 anti-seizure medication at a low dose and remaining seizure-free with that. When I saw him initially at about 3 months, he had low axial tone, increased tone in his extremities, and then at 6 months, similar findings, but especially had motor delay. And then I ended up diagnosing him with cerebral palsy at about 10 months corrected age. This mom was gracious enough to share some pictures of her son for us. So on the left is shortly after he got home from the NICU after a very prolonged stay. And then the second one is more recently. And it's hard to tell in the picture, but his head control has improved. He's doing pretty good with that, but he's still not able to sit up on his own. When I talked to her on the phone a couple of days ago, he's about 15 months corrected now, and he just recently started rolling over. He also does have cortical visual impairment, and so he does follow with ophthalmology as well. And then this is another example. So this is HD. He was born at about 28 weeks, had right grade 4 and left grade 3 IVH. Again, developed post-hemorrhagic hydrocephalus, had a shunt placed. He has had 1 revision so far at 22 months. And then when I saw him initially at about 4 months, kind of similarly to the previous patient, had low axial tone, increased tone in his extremities, motor delay. Saw him again about 7 months, similarly, even more motor delay. But he is almost 2 years old now, and he has mild CP, and he actually is able to walk with assistance. So does have orthotics and uses a gait trainer. These pictures are actually not of him, but I thought the first picture on the top there is pretty similar to how he was when I last saw him in clinic. So he was able to maybe take a few steps independently, but did require some assistance. He does not have any seizures. He did have to get strabismus surgery, and he's been wearing glasses since he was under a year old, but no hearing issues. And he actually is able to say some single words, working on putting 2 words together. He's very social. And then we're planning on getting a more detailed developmental assessment with the Bailey once he turns 2. So I tried to pick kind of 2 similar cases from my patients who were both pretty premature, had bilateral high-grade IVH, had hydrocephalus, needed shunts. But you can see a little bit of the range of outcomes that we can see there. So for the first one, I'm not sure that we're going to be able to get him to walking. But for this particular patient, he's doing pretty well and able to walk at least with assistance. So, and a lot of this I think also has to do with kind of early interventions and such as well, which kind of emphasize the importance of that as well. So yes, I will leave it at that. But thank you so much for inviting me to talk today. I really appreciate talking to you all.
Thanks. It is now my distinct pleasure to welcome our keynote speaker. Oh, can't hear it. Okay. It's my distinct pleasure to welcome our keynote speaker, Dr. Williams. He's a professor of neurology and neurological surgery at the University of Washington, but he is homegrown here. He got his medical degree here at Indiana University School of Medicine. He serves as the director of the Adult and Transitional Hydrocephalus and CSF disorders, and he has expertise across many forms of hydrocephalus. He has helped to create the International Society for Hydrocephalus and CSF Disorders and is past president of that society. He's a founding member of the Adult Hydrocephalus Clinical Network, and he's been very active in patient advocacy. Interestingly, he's also working with NASA, particularly on their spaceflight-associated neuroocular syndrome, which is a disorder that affects astronauts on long-term space flights. So it is my distinct pleasure. I'm intrigued by the title of his talk and looking forward to hearing his insights.
She just warned me the mic is on. Let's do this one, because I don't know about you, but we've had many quiet speakers and I want to be sure that you can hear me. So Bonnie, thank you for giving me an excuse to come back to Indianapolis. I haven't been on campus since about 2008, and before that I hadn't been on campus since 1989. I should probably tell you a little bit about my career. This is where I ended up. That's the view from our apartment in Seattle. Yes, that's the Space Needle there, and those are the Olympic mountains in the background. So I started my career in neurology and then became a neurointensivist at Johns Hopkins in 1989. So I'm actually from the first generation of neurointensivists out there. And it was from there that I developed my interest in hydrocephalus, first taking care of the acute forms of hydrocephalus in adults in the intensive care unit, but then starting with idiopathic normal pressure hydrocephalus, learning how to apply my understanding of the same physiology and pathophysiology to the care of patients with ambulatory forms of hydrocephalus. And I started with the elderly population, which is idiopathic normal pressure hydrocephalus, then young and middle-aged adults, and then eventually the transition population. So children who survive the neonatal ICU, children who have had 44 shunt operations, young adults who then get spit out, literally, of pediatric hospitals and have no place to go. And I actually led a conference that the Hydrocephalus Association had about 6 years ago to identify healthcare transition as a major issue. I'm looking at Mitesh here. We talked about this at dinner last night. So that's a little bit about my background. I had a side gig in biomedical ethics, I should say. I was co-chair of the ethics committee at Johns Hopkins Hospital for about 9 years, and actually chair of the American Academy of Neurology's Ethics, Law, and Humanity Committee. So there's my title, and let's just see if we can move a couple things out of the way here. Because if I can see it in the middle of my screen, I think you can too, or we'll make that disappear. So here we go, maybe. So these are my disclosures, and you can see that I get some research funding from NASA and from Trish, who's not a person, but the Translational Research Institute for Space Health, to investigate ICP in astronauts. Spaceflight-associated neuroocular syndrome looks like pseudotumor cerebri. Astronauts on long-duration spaceflight come back with papilledema. They don't have significant visual loss, but we're trying to understand whether there's abnormal ICP associated with it. Now, Mitesh, the NIH funding that I have is for the PENS trial. And you may or may not know that I actually wrote the PENS trial along with Mark Luciano and Jan Malm from Sweden. And it took us 14 years of work and a couple of visits with the NIH before we finally got it funded. Bonnie mentioned that I've been active with the Hydrocephalus Association and the Hydrocephalus Clinical Research Network. And oh yeah, I came from here. School of Medicine and neurology residency. So I tried to make copies, photos from my copy at home, but I had to go online and find some pictures from the 1985 Caduceus. That's the yearbook for the School of Medicine. And there's Kyle going, yes, IU Northwest, because I went to IU Northwest for my first 2 years. I don't know who that skinny guy in the middle is. I think that's me. But the yearbook had only 2 of the neurology faculty in it. One was Bill DeMeyer. Bill was an amazing pediatric neurologist who taught that the history and physical exam is essential for everything that we do. And Mark Dyken was the chair of neurology at that time. He was a master in the field of stroke. So this is a talk that I've given now for the second time today. And I gave it a year ago at a large conference for primarily young investigators in the field. I thought a lot about how I can speak to young investigators. And can I just see how many of you are at assistant professor or lower in rank? So that would be residents or fellows or students and so forth. Come on, guys. I know you should be raising your hands over here. All right. So any deans in the room? I got a message for you too. Any chancellors in the room? Okay, I got a message for you too, and some department chairs and so forth. So this is, in fact, for all of you, but especially for those of you in the audience who are young investigators and at the early stages of your career, because I thought about my own career when I was putting this together. So I know you all thought that I was going to review the science. Well, I'm not going to do that. And I'm not going to tell you about all the papers I've written. I'll send you my CV if you want to see that. And I'm not going to propose a radical new theory of hydrocephalus. But I hope to inspire you. I want to inspire you to see hydrocephalus differently, more broadly. And I hope that each and every one of you will achieve great accomplishments with whatever role you choose to play in the world of hydrocephalus. That could be clinician scientists. It could be basic scientists, clinician researcher, modeler, physicist, working in Bonnie's lab, working in Becky's lab. And I want to invite you to ignore the naysayers. And those of us in neurology and neurosurgery know that there are naysayers with hydrocephalus. They go, is that all you can research, hydrocephalus? They really think that it's not worthy of study. They dismiss hydrocephalus as unworthy of serious study. They disbelieve in idiopathic normal pressure hydrocephalus, or they take care of patients and dismiss them and blame the problems on the patients, very contrary to the model of David Frim that you heard about earlier. And sometimes I think that ignorance and arrogance hurts people more than it helps. So if you're going into hydrocephalus, I want you to be loud and proud. I want you to be loud and proud that you are studying one of the most complex and poorly understood disorders of the brain that exists. Your work is vital and valuable. It's highly valued by patients and the families that we serve. And I want you to share the same joy. I'm a clinician, the same joy that I get when my patients get better, and to show empathy when they don't, because not everybody gets better. And to be joyful and proud when your research, it could be basic research, it could be something else, has the potential to change the lives of millions of people around the world. And I want you to be as optimistic as I am about hydrocephalus, especially with the launch of a new center here. All right, mandala. How many of you looked it up? How many of you know what it means? Okay, I know one of your postdocs is from Nepal. He should probably know what it means. So mandala is from the Sanskrit for circle. Now, from the Buddhist tradition, a mandala is a representation of the universe, and it can serve as a guide for introspection and meditation. And each mandala's design, representation, meaning, and purposes are a reflection of its creator. Now, I'm not a Buddhist. I'm from Indiana, Northwest Indiana. And I didn't really know about mandalas until 4 years ago, October 2019, when my husband Clifton and I took a trip around the world with National Geographic. And those are some of the pictures, and it really was an unforgettable trip. But 2 of our stops were in Kathmandu, Nepal, and Lhasa, Tibet. And walking through Nepal with our guide, we went to an art school. And we stopped and we learned about mandalas, and we actually bought 2 of them. They were the 2 I showed you in the picture a minute ago. And following that trip, and as I thought more about mandalas and what they represent, I eventually realized that I had created a mandala for hydrocephalus through the course of my career. It actually represents my thoughts and my visions about hydrocephalus. It guides me. It's my worldview, my universe, and I want to share it with you. Now, the creation of the mandala has lots of influences, and these are some of mine. I see the world through the eyes of a neurologist and a neurointensivist and a hydrocephalus expert and an ethicist. And my eyes and my perspective were influenced by many people through the years. Now, the mandala was something that I really was unaware of for quite a long time, at least the first half of my career. It was there, and maybe it was gestating, I don't know what, but it was latent. It was undiscovered until I was given the opportunity and the responsibility to change everybody's perspective on hydrocephalus. And that was the 2005 NIH workshop on hydrocephalus, the first ever NIH workshop on hydrocephalus. And the backstory is that Dory Kranz, who's second from the left in the picture there, who was the executive director of the Hydrocephalus Association at the time, had contacted NINDS and had arranged a full day of meetings with the staff and with the director of the NINDS, who was Story Landis at the time. And Dory calls me up and says, "Can you join me next week?" She gave me a lot of notice, but fortunately it was an administrative day for me, and I was able to make it down there with her because Bethesda was not too far from Baltimore, where I was at the time. And we were supposed to, at the end of the day, have about 20 minutes with Story Landis. She ended up giving us an hour of her time, and that's usually a good sign when somebody at that level gives you more time than you were expecting. And Story said, "Yes, you can have the workshop. Normally, it requires a competitive application." She said, "No, I'm going to give you the money to make the workshop happen." And so we got to work just a few months later with the staff from the NIH to make this workshop occur. And it wasn't just a US conference, we had international participants. But our motive from the very, very beginning was to intentionally and completely redraw the prevailing view of hydrocephalus, knowing that we would write a white paper and that would set a research agenda for many years to come. Now, I got to give a talk. I was in the first session, and on the left is actually one of the slides. This is the slide that I showed at the NIH conference. So orthodoxy. And the orthodox view, Mitish knows this, was that hydrocephalus was a disorder of CSF circulation and resorption. And since shunts had been invented in the mid-1950s, hydrocephalus was cured. We heard that all the time. Well, hydrocephalus was cured. And that's how everybody thought about it. It was a plumbing problem. And scans and shunts, and that's it. And if you have a cure, well then, who needs research, right? Who needs research? And so in my next slide, I said to them, well, you know, because I take care of these patients, shunts and ETVs are merely a means to an end. They're necessary. We need them to get patients better. But the focus on CSF circulation made everybody completely missed the most important goal of treating hydrocephalus. So then I told the audience, hydrocephalus is not a CSF disorder. And I think we heard one of the junior neurosurgeons say that today. It's a CSF disorder, but it's not. Hydrocephalus is a brain disorder. It's a brain disorder. And the most important aspect of hydrocephalus, and idiopathic normal pressure hydrocephalus is one of the best examples. You have somebody who has symptoms for weeks or months or years, and we treat their hydrocephalus, and they get better in days or weeks. And that means that there is a reversible neuronal and glial injury that's responsible for the symptoms and the recovery of symptoms. And this is very unique. There's no other disorder that's quite like it. So a unique form of reversible neuronal and glial injury. And so by asking 3 simple questions, what in the world is happening to the brain as a consequence of hydrocephalus? Why is it happening? And how do the injury and recovery mechanisms in hydrocephalus work? The mandala was born, and here it is. This is the slide that I showed at the NIH workshop. And remember, I didn't figure out it was a mandala until many years later, so I didn't call it that. I just showed the slide. But in a single image, it summarized the new universe of hydrocephalus that we wanted to promote as the basis for research and clinical care moving forward. Now, if you think I'm exaggerating, look at this. This is the white paper. On the right is table 1. Everything in that mandala is on table 1. It's really not very inspiring. It's just a list. Now look at that mandala again. And now you can see how each circle, each concept is related to the next. It starts at the top with reversible neuronal and glial dysfunction, reversible symptoms, injury and recovery mechanisms, down to laboratory and clinical models, surgical therapies, adjunctive therapies, eventually research. That's the circle of hydrocephalus. And you can see at a glance all of the concepts that we wanted to promote and all of the work that needed to be done. And you could see at a glance the complexity of hydrocephalus. And in your mind, you can see the potential for research bridging disparate concepts. In your mind, you can see where you and your work fit into the mandala of hydrocephalus. And since 2005, since I drew this, this is how I have seen the universe of hydrocephalus. Now, skeptics, and there are plenty of them, would say, well, isn't that nice? But has it done any good? So let me show you. So remember, Jack Walker and Pat McAllister, who Mitesh wrote his first paper with many, many years ago, and I worked with the Hydrocephalus Association on the workshop. Well, the Hydrocephalus Association is the largest patient advocacy in the United States, in fact, in the world, for patients and their families with hydrocephalus. And their members, like the Finlaysons, wanted better research to result in better patient care and better outcomes. And the Hydrocephalus Association has advocated consistently with the NIH and with the US Congress, which means the CDMRP, which is the source of some of Bonnie's work, to promote hydrocephalus since then. But here's the problem. To get an NIH grant, you need preliminary data. And you can't get preliminary data unless you have funding. And so the Hydrocephalus Association started to raise money for research. And we do this mainly through walks every year. Do we have a walk here in Indianapolis for hydrocephalus? I'm going to put you on the list. I have an assignment for you, Mitesh. Yeah. So we started raising money 14 years ago, and we began to fund young investigators, mentored young investigators, pilot research, and other innovative research. This is what got Bonnie started. In fact, we were working with the Rudy Schulte Research Institute more recently, but the Finlayson family from the very beginning. And we have raised over $14 million. We've turned that into research, and our researchers have gone on to get another $74 million of additional grants. So I think we know how to pick them, because they're going on and being really, really successful in their work. And just here on the right side, you can see what we've done: 61 research grants, biobanks, the research networks, a couple of NDAs and so forth. So yes, it has indeed made a difference. So here it is again. And it's kind of old, it's stale. It was made in 2005. I don't dare ask how old this side of the room was in 2005. But look at the 4. Thanks. That's me plus 61. Around that plus 61. So, but look at the scope of it. And I want you to think about all of the work it represents, all of the ambition, all of the discoveries that are there. And if you are young, you who were just 4 years old 20 years ago, you may be saying, oh my gosh, how am I going to stay on top of this? How am I going to follow injury and recovery mechanisms and neural networks and AI and so forth? And how can you stay current? And I'm going to tell you that you can. And the one thing I want you to know is I was junior when I first drew this. I had just made the jump from assistant professor to associate professor. So I was youngish. I was just out of the junior career. And so you can do it, but you have to develop good habits. And the way that I did that was to constantly, incrementally update my knowledge. I didn't try to do it all at once. I said, let me use PubMed and let it do the work for me. So this is the search that I set up a long time ago. And for probably more than 17 years now, every Sunday I get an email from PubMed that says, here's the most recent hydrocephalus literature. It's actually looking back at the last 180 days, but because I get it every week, it's really telling me what's 180 days a week ago, or a week ago, 180 days. But I get 25 to 75 new papers per week on that list, depending on the list. Now, I don't read them all. I got other things to do with my time. And I find and save about 5 or 10 papers per week, but I've seen the list. I know everything that's out there. And so that helps me in case I hear of something in the future. And this is just a sample from 1 week last summer that I collected. So here it is again. And the science has changed since I first created this. It's been 19 years since I created it. And many people who are in this room have helped to make that happen. Well, the science is advancing, and that means that the mandala needs to change as well. So I've updated it. And this is the new version of the mandala. And if you want to see how they compare, let's put them side by side. And one critical change that I made was up at the top in the middle, I put brain water dysfunction because it really is a brain circulation disorder that instigates everything else that follows. And I made this change after attending a conference in Copenhagen with Nana Macaulay on brain water. But we now have genetics in there. We have complications and comorbidities in there. We have gravity physiology, because I certainly am learning in my work with NASA that if you think you understand physiology, take gravity out of the equation and you don't know what you're talking about at all. And so what I want to do next is actually show you what's changed in the research. So a year after the NIH workshop, we had the first big meeting in Gothenburg hydrocephalus meeting. So this was 2006, and this is actually before the white paper was published. And I went through the abstract book and started to make a list of things that we're talking about now in the science that we didn't have in 2006. So I've got a lot of categories here. Look for the zeros and the ones. Those are the areas where essentially nothing was happening. Aquaporins, lymphatics, brain water transport, cellular and subcellular physiology of microglia, inflammation, mitochondria, novel chronic animal models of hydrocephalus, genetics. We learned so much more about genetics, patient-centered outcomes, health economics, gravity, registries, research networks, training the next generation of specialists, which is a bigger challenge in adult hydrocephalus than in pediatric hydrocephalus. And this, if this is the progress that we've made in the 17 years since the Gothenburg meeting, imagine what it's going to look like 17 years from now. So we created a new vision of hydrocephalus in 2005, and all of these things that weren't there are now on the radar screen, and we made that happen. So I use the mandala all of the time. It really is fully integrated into my thought processes, my reasoning, and my being. And when I see patients, I try to see the world through their perspective, their hopes, their fears, their goals of care. And I see patients from age 18 all the way up into their 90s. And when I take care of them, I look beyond the horizon. It's not just, oh, well, shunt's obstructed, fix that. I call that the forest fire model, Mitesh. You know, everybody's putting out fires, but nobody's asking why are there so many fires? I look beyond the horizon. It's not just to take care of them this week, but to keep them well all the way through. And when I work with my colleagues, I think about their perspectives. I understand or try to understand the neurosurgical perspective, adult and pediatric neurology, neurosurgery, neuropsychology, rehab specialists, basic scientists, physicists, clinician researchers, policymakers. You have to understand how everybody who's represented in the mandala thinks about hydrocephalus. Their views are important, and you can incorporate that into your own thinking and reasoning. So when I listen to your presentations, and I did that this morning in Bonnie's lab, or when I peer review grants and papers, I'm thinking about the mandala and thinking about the significance of the work. And I incorporate that into a mission and a vision. So you start with a vision, and mine is that every patient with hydrocephalus at every age and every stage of life should mature and advance successfully to the next stage of life. You like that mission, Kyle? That's a good mission for hydrocephalus. Vision. And that sets up our mission. And it's mostly a clinical mission here, but I'm going to tie it all together in just a second. So when we see patients with hydrocephalus, our mission is to provide the care they need to get them through the entire lifespan. So when I get an 18-year-old in my clinic, I'm thinking about getting them to 78, not just to 19. And that becomes not an academic triad that everybody talks about, but it's an academic tetrad. And I encourage you to change from a triad to a tetrad, not patient care, teaching, and research alone, but advocacy. The Hydrocephalus Association advocated for us, we advocate for them. We wouldn't be where we are today unless we had participated in advocacy with the Hydrocephalus Association over the last 20 years. So where's IU on the mandala? A bunch of different places, I'm happy to report. So there's Bonnie Blazer-Yost's work to develop medical therapies along with Terry Bellicki-Adams and Lauren Jancy, and they're all working together. Tim Bentley talked about the large animal model. Jignes Taylor presented work on ETV. Is he still in the room? There you are back there. There's some interesting stem cell work you could be doing in hydrocephalus. We're going to pull you in for that. We mentioned the NIH trial and so forth. Kyle, I think your story speaks for it itself, and the Hydrocephalus Association is here for you. And so I would say that Indiana University is ahead of most other centers. I'll tell you, at University of Washington, I don't have a group like you. You know, ours is predominantly a clinical program. So for the young people, I encourage you to appreciate the people, the specialists and the researchers on the mandala, to appreciate the patients, whether they're neonates or children, adults or the elderly, and their families, to appreciate the setting where the work is done, academia, community hospitals, resource-constrained settings. And I think the work of Steve Schiff was amazing to me, unraveling what's happening in resource-constrained settings in Uganda. And I want you to recognize where you exist in the mandala, how your talents and work fit in and contribute to the overall goal, to recognize the opportunities to work with others, and to recognize how apparently unrelated research like renal physiology research that Bonnie Blazer-Yost was doing 8 years ago is in fact relevant to hydrocephalus. And I encourage you to envision and create the future of this mandala. Create your own mandala. You can start with mine if you want, I don't mind. Use it for introspection and meditation. Strive to know the entire mandala, incorporate it into your being. And if you do that, then I'm really optimistic, because I know that in this room, there may be the person or persons who are going to discover key biological mechanisms for reversible neuronal and glial injury and recovery, who might discover the biological mechanisms of brain, water, and CSF regulation and flow, who might lead the first clinical trials for drugs or biologics to treat hydrocephalus, who will figure out the biocompatibility of shunt catheters to make them better, and who might discover better biomarkers. And there might even be somebody in the room who discovers cures for the prevention and treatment of hydrocephalus. And lastly, for the young people in the room, there might be somebody standing here in 25 years at the anniversary of the program giving a keynote speech. Thank you.
I think Mike embodies what I have found in the hydrocephalus research. Oh, Mike, thank you. Mike embodied in everything he said what I have found in hydrocephalus research. It's been an amazing 8 years since I transitioned from renal physiology. And it's amazing how much the research has grown over that time. From a few labs doing this to a multitude of labs, and these are interconnected labs. Many of us know each other's students. We see graduate students going to other people's labs as postdocs and then on to their junior faculty positions. It is a close-knit field. It's been quite an honor to be part of that. And it's also an honor now to actually introduce the Finlinson's family. 3 members are here, Pam, Peter, and Grant. There is another member, Sam, who couldn't join us today. But Pam is going to tell us this family story, but I'm going to spoil it a little bit. Sorry. Can I talk about Team Hydro just a little bit? Okay. Okay, I don't want to spoil the point. Okay. No, I don't want to spoil your story. I haven't seen your slides. They are raising money for hydrocephalus research and have been for a very long period of time. They funded the pilot project that allowed me to get into this field. And I've known them ever since. So the way that they raise money is that they support a swim because they're big swimmers. In fact, I understand Peter's picture is over in the NFL, the Sports Hall of Fame, as a water polo player. He didn't know that. He just discovered it on this trip. So they set up a number of different swims, but the one that is most remarkable is the Alcatraz swim. So yeah, you too can do this swim, I understand. I'm looking at the young people who could do this swim. Every year they swim from Alcatraz to the mainland to raise money for hydrocephalus research. I thought that couldn't be done. I remember hearing about Alcatraz as an island that you put a prison on because nobody could get off of it. Well, apparently you can, under the right circumstances, make that swim, and they haven't lost anybody yet. So I won't take up any more time. I'd like to introduce Pam as the speaker for the family. And afterwards, I encourage you to talk to all three members of the family. Do you want to use this or the, which you're more comfortable with?
Yeah, I think I'm going to give it a try. Anyway, oh, thank you so much, Bonnie. My family and I couldn't be more thrilled or excited by the opening of this amazing center. We could also not be more grateful for the incredible and groundbreaking work of Dr. Blazer Yost that has allowed this important place of research and learning to come to fruition. As folks who first met this brilliant researcher, I'm going to embarrass you and Al a little bit too, now also considered a dear friend, when she was just beginning her first foray into hydrocephalus research. We have long been amazed by her keen intellect, her determination, and especially her willingness to attempt a journey down an unpaved road. Yet despite already being aware of all this woman is capable of accomplishing, we could not be more moved or excited by what we've also seen here today. Clearly, the team with which Bonnie surrounds herself, as well as those who came here today or are listening online, because of your own interest and work regarding hydrocephalus, are beyond incredible too. Thank you all. My family and I also want to express how very honored and touched we are that Dr. Blazer Yost and Dean DeTusa asked us to share our daughter and sister's experience with hydrocephalus. I hope that as I do, it will not only give you reason to pay attention to what Dr. Williams just said and listen to all the opportunities available in this field, but also to maybe, again, for a moment, make it personal and remind you of the people for whom your efforts and work and thought and caring will really make a lifelong difference. Oops, did I already mess it up? Right. I think I pushed the wrong side. No, let me just, yeah. There we go. This was Kate. And she passed away from complications of hydrocephalus at the age of 26. She would be very surprised and yet also very pleased, I think, at the idea that her life, in its turn, might ultimately, in a small way, contribute to improving the fate of others. Her hydro family, as she used to say. Our Kate was an inspiration. Sadly, her life was also a powerful demonstration of the pressing need for increased and continued hydrocephalus research. For some reason, it's not flipping for me. Should I go here? This one? Should I just do this one? No. Just the arrow. Okay. I'm sorry, everyone. Unlike most parents whose child is diagnosed with hydrocephalus, I had heard of the condition before Kate was born. In college, I had volunteered teaching adaptive aquatics, swimming for people with mental and physical disabilities. My very first student was a little boy, about 3, who had untreated hydrocephalus. Scotty was blind, his head so large and out of proportion with his small frame that he couldn't even hold it up. I loved that sweet little boy. When he died a year later, I hoped never to encounter hydrocephalus again. Fast forward, I'm married, living in Boston, expecting my second child. At 25 weeks gestation, my water breaks unexpectedly. 10 days later, Kate is born 3.5 months early. Weighing barely 2 pounds, she was very tiny and very sick. We were told to prepare for her death. Against all odds, somehow, however, she miraculously survived the first couple of days. But before we could breathe a sigh of relief, she suffered a severe brain hemorrhage. Left grade 4, right grade 3. The medical staff, which had already been less than encouraging, went from less than to not at all. We were told that even if Kate survived, she would never walk or talk or develop normally. Back in those days, they used words to describe her like train wreck and vegetable. But when I looked at my daughter, despite the fact that she was lying in a frightening tangle of tubes and wires, in her eyes, I saw a spark, an unmistakable light saying, "I'm still in here. Don't stop trying." And so we kept our hope alive. But as a few weeks passed, Kate stalled. She grew more lethargic. Her vital signs tanked. As I sat by her bedside, her head began to enlarge from 1 hour to the next. Imaging was done. Her head was full of fluid, her sweet brain crushed up against the inside of her skull. The doctors and nurses were clearly worried. I heard a term I hadn't heard in some years: hydrocephalus. My thoughts, of course, immediately turned to Scotty, his physical challenges, his early death. Would this now be the fate of my precious little girl? But as pressure climbed in Kate's brain, the doctor said something could be done. They could place a catheter in the ventricles of her brain to drain the excess fluid, something called a shunt. Brain surgery. It seemed scary, but as Kate deteriorated, a shunt seemed like a miracle. They could place a catheter in the ventricles of her brain. Kate would have a chance with this thing called hydrocephalus. Still, she would be shunt dependent for life. A shunt was placed. Kate's brain popped back, and her condition stabilized. Miracle. We were grateful and full of hope when we finally brought our little girl home. Despite the gloomy predictions for her future, Kate began to grow into an adorable little girl who loved life. In the next 10 years, she needed only one shunt revision. That's not to say there weren't challenges. We worked with Kate every day to overcome learning and language delays. Since one side of her body didn't work as well as the other, we started her swimming as therapy because it forced her to use both sides equally. Kate loved the water. At first, she was like a boat with one oar and only went in circles. But she kept trying and working. And eventually, the skinny little girl with bifocals and a brain shunt became a champion swimmer. To our amazement, most of her records still stand. And at her swim club in Maryland, Kate's dedication and perseverance in spite of diversity remains somewhat of a legend. In fact, her love for swimming is one of the reasons why our family takes pleasure in earning funds for research through swimming-related events. And wonderfully, the Little Falls swim team in Bethesda, Maryland, has joined Team Hydro and often holds a yearly swim for hydrocephalus research, raising much-needed funds for the condition that took the life of a teammate. Kate's perseverance paid off in other aspects of her life, too. She became a good student, an avid reader, a gifted writer. Most importantly, Kate was a happy, loving girl, a joy to be around. We decided then that hydrocephalus perhaps was not so bad after all. But when Kate turned 11, everything changed. Her shunt, a dream come true for a lifetime, for a decade, became the nightmare of her existence for the next 15 years. Kate began having debilitating headaches. Sure enough, shunt failure. Surgery to remove the old shunt caused another brain hemorrhage, creating another area of the brain that would not drain on its own. An additional catheter was placed, but this caused overdrainage of the fluid. Another surgery for a different valve was needed. Just when this series of complications seemed finally over, a life-threatening surgery-related infection struck. The dynamics in Kate's brain changed further, making her hydrocephalus forevermore incredibly difficult to manage. We were beginning to really not like shunts. Don't get me wrong. In many ways, shunts are wonderful. When working, they keep people alive. But as we've heard today, they're horribly flawed. They are notoriously prone to problems and failures. Shunts can clog, break, fall apart, get infected. Valves can over or under drain. Catheters can corrode, disconnect, erode through the skin, even manage to tie themselves in knots internally in the peritoneal cavity. Revision surgeries can cause seizures, motor issues, strokes. We know because during her lifetime, every single one of those complications and a whole lot more happened to our daughter, Kate. Each one required more brain surgery and days, weeks, or even months in the hospital. Shunts can fail quickly. One day, Kate was happy and energetic all morning, but just after lunch, I found her lying on the couch looking tired. "Are you okay?" I said. "Well, Mom, to be honest, I have a headache, and I think I may be the bad kind of sleepy." To my mommy ears, bad kind of sleepy did not sound good. Sure enough, an hour and a half later, Kate was being wheeled into the OR, the pressure in her brain so great we couldn't wake her up at all. Yet no one seemed to understand the science behind these failures and complications, much less what to do about them. So often the answer to Kate's questions regarding what was happening to her was, "We don't know. We just don't understand." Or worst of all, we really are not sure what to do next. The problem is, until we understand what is going on with hydrocephalus and find better treatments, or even better, how to prevent hydrocephalus from developing in the first place, people like Kate will continue to suffer and die. Living with the uncertainty of a relatively unknown, incurable condition is not easy, and yet it forced in Kate a maturity and compassion beyond her years. We were in pre-op. Kate was about to have a particularly dangerous surgery. Her calm demeanor belied the fact that she understood the gravity of the situation. She took my hand and said, "Mom, I'm a bit more nervous today than usual." She paused. "When Dr. X looks at me, I see fear in his eyes." She then very calmly added, "If things don't go well today, will you please tell him it's okay, it didn't work?" There was Kate, just 14 years old, seeking to comfort her beloved neurosurgeon because she knew her case was pushing the limits of even his skilled expertise. It broke my heart. Kate survived complication after complication all through her teens. She survived things like this. Her shunts failed so frequently, attending regular school was impossible. She had to stop swimming, never made it to prom, missed family reunions and vacations. Despite dozens of surgeries and the added isolation of independent study, through sheer determination, Kate graduated high school on time. She was admitted to college as an honor student, where she hoped to fulfill her dream of becoming a nurse. Kate said she couldn't imagine helping others as she had been helped. Sadly, her studies and dreams were cut short by surgery after surgery due to her shunts. In her early 20s, Kate's symptoms grew even more difficult. She was in constant pain. Her heart, which, as you know, is controlled by the brain, acted up. If she remained upright too long, she would suddenly fall unconscious into a coma. It seemed clear she was suffering from an internal leak of some sort, causing her brainstem to shift downward, but imaging technology could not find it, and blind attempts at blood patches failed. As an adult, Kate had aged out of her children's hospital and pediatric neurosurgeon. We needed to find an adult neurosurgeon who was willing to take on such complex hydrocephalus, not an easy task. We were finally referred to a doctor in another state. Kate and I traveled expecting to be gone a couple of weeks. I'd remain for over a year and a half. Kate would never return home. The first surgery was simple, a valve change, but copious amount of fluid started leaking from the incision. A terrible infection developed. Treatment caused another stroke, a big one. More surgeries, more changes to her brain. She began developing loculated areas within her ventricles. And even if they appeared small, it turned out that unless they were individually shunted, she would become symptomatic, as in she'd go into a coma. Soon she needed 5 catheters draining well to remain conscious, but her CSF began generating an odd spider web-like substance which kept clogging them up. But worse than all that, they could not stop the leaks. Kate's tipping point became very narrow, an extra 3 to 5 cc's. That's about a teaspoon. A fluid in her head put her into a deep coma. The fact that the brain can be so resilient and yet so fragile proved as difficult as it was amazing. Still, Kate's brain just didn't make sense with regard to current knowledge of how the brain and CSF system supposedly works. What happened next was no less than horrific. For a period of about 4 months, Kate was operated on just about every other day. She'd return to the ICU from surgery awake, relieved and talking, only to have her shunts fail again within hours. Back in a coma, she'd return to the OR. The cycle would then repeat. Kate was devastated physically. She lost most of her vision and the use of her left side. Her right side lost function too. She could not tolerate sitting up. The skin on her head became so fragile, it would tear like tissue paper if it even touched her pillow. Her pain was intense. As complications continued to mount, a solution seemed nowhere in sight. Her doctor was clearly frustrated. Kate's brain was not following his theories regarding hydrocephalus in the brain. After months of effort, he seemed kind of relieved to leave town for the holidays. In an unexpected turn of fate, the holiday would bring new hope. We met a bright young doctor covering Kate's case, known to think outside the box. He studied her case, listened carefully to our observations, asked some great questions. He conceived and proposed a novel solution, a new system designed to force CSF through the shunt before it could leak out elsewhere. But this shunt would need to be pumped manually. He offered no guarantees, but Kate and our family, who would need to pump the shunt, decided to try. Kate was determined. We were desperate. The novel system was jury-rigged together and implanted. The doctor provided a general calculation on how much we needed to pump the shunt, but warned us not to do it too much or the ventricles would collapse and clog the catheters. So back in the ICU, her nurse and I started slowly. First, we pumped her enough to pull her out of a coma. Then we pumped her enough to keep her out. Eventually, we found the shunt needed to be pumped 70 times every 15 minutes around the clock. But you know what? The system worked. For the first time in months, Kate became more stable. The external leaking began to slow almost immediately. Her headaches diminished to a stop. Kate and all of us were so excited. We celebrated a joyful Christmas in that ICU. Kate had a long road ahead of her and was still shunt dependent, still requiring all 5 catheters. But buoyed by new possibilities, she was ready to conquer the rehabilitation she faced. The next part of the story is difficult to tell. The first neurosurgeon returned from vacation. He heard about the newly invented system and the pumping it required. We were surprised to learn he didn't like the idea. We excitedly told him how much better Kate was doing. She had stopped needing surgery. The leaks were healing. He was skeptical. When he came to see Kate, she was resting, but he must have assumed she was back in another coma because right there he suggested we stop pumping and just give up. We were confused. Kate was finally improving. Why would we stop now? He said the pumping was not sustainable. The doctor continued, "It won't work. I recommend you just say goodbye to her and stop. Just let her go. She won't know." Grant and I and the nurses in the room didn't know what to say. It was Kate herself who first found words. Though lying in bed silently with her eyes closed this whole time, Kate opened her eyes and said in a quiet but firm and pleading voice, "No, don't not try." Tears began to roll down her cheeks. "Please, don't not try." Kate wanted to live. Despite having endured so much, despite facing a long road ahead, Kate was not ready to give up. Kate wanted to try. We continued to pump her shunt. No more comas. The leaks healed. As they did, she required less pumping. Eventually, the system drained on her own. Her headaches were gone. The problem that brought her to the hospital had been solved. In the next 10 months, Kate joyfully accomplished a lot. She worked hard to learn to sit up unaided, then to walk again with aid. She served others by making care packages for her physical therapy and allowed doctors to study her unusual case. She got to know her future sister-in-law, and albeit in a wheelchair, Kate danced with her brother on his wedding day. And although she was unlikely aware of this, she continued to teach and inspire her family, friends, and medical staff about strength, courage, hope, and love. Most importantly, Kate remained grateful for every day she was alive, as did we. For our family, an important takeaway from Kate's life is recognizing how transformative it is when someone asks the right questions needed to formulate and attempt a new solution. We tried, and it worked. Tragically, this solution came too late. A powerful infection reemerged in her shunts. This time, even Kate knew it could not be stopped. But Kate's death drove our lesson home. We can't be satisfied with the way things are. We must keep fighting this thing called hydrocephalus. Despite progress in recent years, research is still sorely lacking, and the current treatments, all of which require brain surgery, are simply not good enough. No matter how well a shunt works on a given day, or even on occasion for a relatively carefree decade, without the generation of new understanding and treatments, shunts will remain what they are, ticking time bombs of potential disaster. With no treatment, sweet Scotty had no chance. Our Kate had access to dedicated professionals and incredible medical care. Yet because understanding of and treatments for hydrocephalus remained outdated and lacking, she still suffered unimaginably. Despite so many surgeries, despite all she endured and survived, in the end, hydrocephalus stole her life. We need to do better. We have to try. It's easy to say no one should suffer as Kate did. It will be harder to ensure no one must. We need more and continued research. We need real understanding of how and why hydrocephalus develops. It's worth the effort. It won't be easy. We need new solutions. We need a cure. Or better yet, imagine a world where we can prevent this devastating condition from ever developing at all. It may be too late for Kate, but the situation is urgent for the millions throughout the world still suffering with hydrocephalus and those yet to be diagnosed. It won't be easy. To keep this cause moving forward, it will take commitment and determination and perseverance, the very things we demand of hydrocephalus patients every single day. It's worth the effort. I still miss Kate. In all those days and nights we spent together, she became my sister and my best friend. She would be so pleased and amazed by this incredible center and by the research that has been presented here today. Kate would have certainly been first in line to thank each of you for your willingness to use your incredible brains to think, hypothesize, experiment, and study in an effort to help others. I haven't spoken much about our Team Hydro effort, the one where I allowed my kids to convince me about a dozen years ago that I could swim in the freezing cold water from Alcatraz Island to San Francisco or across the Boston Harbor to raise awareness and funds for hydrocephalus research. Perhaps I should note that the boys first decided to raise funds while Kate was in ICU after a particularly horrible surgery. Once again, her brain and CSF system were not responding in confounding ways. No No one understood why or how. The docs were as perplexed as we were by the disturbing scans and her alarming clinical state. I will never forget the boys, just college students themselves, sitting in the ICU with laptops on, desperately searching the web, hoping to find answers. We knew then that more research had to be done. So the boys, along with just a couple friends, decided to swim in an effort to raise research funds. The idea seemed novel and even a bit crazy. But luckily, novel and a bit crazy sometimes pays off. Donations from this, one of our first earlier swims, funded Bonnie's first hydrocephalus project through the Hydrocephalus Association's Innovator Award program, and another one more recently. Thanks to Bonnie, you don't have to see that being a little bit crazy sometimes pays off big time. And so we continue to swim, making the crossing from Alcatraz to San Francisco each summer. In that treacherous and freezing cold bay, even me, now firmly in my Medicare years. That said, I share a confession with you now. I was never a competitive swimmer, and I hate being cold. Every time I step up to start one of those swims, I look out at the expanse of churning, frigid, marine animal-filled water before me, and my first thought is to turn and run. But it's then I hear a sweet and familiar, but desperately pleading voice in my head. Don't not try. Please, don't not try. It's then I remember why I swim. It's then I remember why promoting hydrocephalus awareness and research is so very important. It's then I remember that as an individual, a family, and a community such as this, until a cure is found for this difficult and life-threatening condition, we can't not try. And thanks to all of you, we won't stop. Thank you so much. Our daughter and sister Kate is smiling for sure. Thanks.
For the very few in the audience that don't, this is John DeTusa. He has been the Dean of the School of Science through the pandemic and has done so much to take us through our new phases and has helped with establishing the center that we now have. So I think Dean DeTusa would like to say a few words and then introduce our chancellor, who has come to say a few words as well.
Thank you, Bonnie. And thank you, Pam. I really appreciate you sharing that difficult story. And I think all of us are deeply touched. I think you wouldn't be human if you didn't have a tear in your eye after hearing what your family has been through. And it provides incredible motivation for this center. I don't think we need any further motivation for this work. I do have the difficult task of following that, and that is not easy. I also want to thank your family for the work that you've been doing for the hydrocephalus community. It really is both impressive and inspiring. I've enjoyed the day very much. It took me away from my usual administrivia to hear about science, first from our wonderful students, and then from both sides of Michigan Street here. So it was really nice to see all of that and to hear what's going on and even the talks from elsewhere. So thank you all for making this a really special day. But now it's my distinct pleasure to introduce the interim chancellor of IUPUI, Dr. Carol Ann Murdoch-Kinch. Carol Ann is a trained dentist. She attended the IU School of Dentistry at IUPUI as a graduate student, pursuing advanced dental specialty training. It's following you, you know, that I'm stumbling all my words. You know that, right? Okay. Attended the IU School of Dentistry at IUPUI as a graduate student, pursuing advanced dental specialty training, as well as her doctorate. Here, she learned the power of collaborative interdisciplinary clinical research and interprofessional collaborative care, which inspired her to develop and lead interprofessional education and collaborative care programs later in her career. After service on the faculties of the University of Detroit Mercy and at the University of Michigan, Dr. Murdoch-Kinch returned to Indianapolis and to IUPUI, and we are very glad that she did in 2019, when she was appointed Dean of the IU School of Dentistry. She was named interim chancellor this past June, and she took on a very difficult job. Again, we are very grateful for her work as interim chancellor. Please help me welcome Carol Ann Murdoch-Kinch.
Thank you. Well, thank you so much, Dean DeTusa. And thank you all for being here today at this inaugural Hydrocephalus Research Symposium. I'm so glad to see so many people in the room, and also I acknowledge there's quite a few of you joining us virtually online. I want to recognize our partners at Johns Hopkins University, Purdue University, IU Health, and the IU School of Medicine, as well as the team here in the School of Science. I'd also like to offer a special word of thanks to Dr. Bonnie Glazer-Yost for her leadership and vision, not only for organizing the symposium, but for advancing such exciting and promising research towards treatments and cures for hydrocephalus. Finally, my deepest thanks to Pam Finlayson and her family for being here and for sharing your daughter and sister's Kate's story. So powerful, and as John said, you know, my heart is beating fast. You've touched all of us, but reminds us of the reason why this is so important that we work hard to find a cure. Knowing about Kate, your family, and the important work you are doing to support hydrocephalus research puts heart and soul into what scientists and clinicians like those who presented today are doing. It connects their work in the lab with the people across the country and around the world whose lives will be utterly transformed by new treatments and especially by a cure. And making connections is what this work is all about. Connections between people, between research teams, and between institutions. This symposium gives us a glimpse of what can grow when the right people, all of you, connect in the right place at the right time. And I would say for the right reasons. This Indianapolis campus, soon to be IU Indianapolis, is the right place. Here, our strong history of scientific and medical discovery sparks with energy, ideas, and innovation. Our School of Science is situated in the heart of the expanding science and technology corridor, which will be one of the defining features of our new IU Indianapolis campus. Our city as a whole is home to a vast healthcare network, including Riley Hospital for Children, less than a mile from where we sit today. Tied to that network is our thriving bioscience research and pharmaceutical industry, including Roche, Eli Lilly and Company, 16 Tech, where ideas, treatments, and cures move from the bench to the bedside. Our campus has long been known for translational bench-to-bedside research, with programs like the statewide Indiana Clinical and Translational Sciences Institute and our campus-wide Center for Translating Research into Practice. Our researchers translate and apply observations and discoveries in the lab, community, and clinic into life-changing diagnostics and treatments that improve health and save lives. This focus on results breaks down walls between departments and schools and encourages the kind of multidisciplinary, convergent, and multi-institutional collaborations that we see at this symposium, as well as in other schools and departments across campus. In this case, that kind of bench-to-bedside collaboration is key to our progress. We envision the work being done right now at the new Center for Hydrocephalus Research will lead to clinical trials and ultimately to treatments for patients. All of this relies on the proximity and collaboration that exist on our campus. Our symposium attendees range from scientists in our biology department to medical researchers and clinicians, as well as patients and their families. Our team of experts and our track record of diverse community building successes make IU Indianapolis the ideal institution to spur progress on hydrocephalus and other chronic diseases. For me, and I think for many others, stories like the Finlaysons serve as a powerful reminder of our purpose, the reason why we do research. It's about improving people's lives. These stories link our research to practice and inspire us to work even harder to make that next discovery that could lead to a cure. With IU's $250 million investment in biosciences announced this past Monday, now is the time to continue building connections that strengthen our community of researchers, clinicians, and supporters. There's no limit to what we can do, what we can achieve together. This is truly an exciting time for research here in Indianapolis, and I want to thank you all again for being part of this symposium and for helping us build this important community. Thank you.
I know I'm supposed to be doing closing remarks, but I think that our chancellor has beautifully summarized all of the excitement we're feeling here in Indianapolis with the changes that are coming. And we hope that the research corridor is very successful. And I thank all of you for being here and for participating in this first symposium. I hope we have more to come. I'm looking at the people that had to organize it and say, you're going to be there, right? But thank you all. We now have refreshments set up. We'd like you all to join us and to thank again the speakers for their powerful messages. Thank you.